Okay, hello and welcome everyone to the Team FRCR 2B external session. And we have Dr. Ankit Balani with us. When he sent me, I wanted to put some of his details in the name. And when he sent me, I said, this is a whole chapter from a book. So you can see he's, mashallah, very accomplished, a long list. But what I want all of you to remember about him is that this is the guy who scored an 8 in the Viva. So without taking any more time from you, Dr. Ankit, please go ahead and the screen is yours.
Thank you, Dr. Sabahat. Thank you for the kind introduction. Hello, everyone. I am Ankit. I am a practicing consultant here in India. Uh, uh, in the coming 15-20 minutes, I would first try and give you some tips and tricks. These would not be to score an 8 on 8 on a Viva, but I would focus on how we could clear 2B in your, hopefully, the first attempt or whatever attempt you are taking this time. So if during the talk you have any questions, please feel free to send me a message on personal chat so as to not disturb everyone in the group. And I'll try and take them as many as I can during or after the talk is over. So here are my disclosures. There are no relevant conflicts of interest, no financial disclosures, and there has been fair usage of copyright work. So as you all now know that there are 4 components to the examination, we'll just briefly talk about the marking scheme because that's all what our focus should be. So there are 4 components, that is one of rapids, long cases, Viva 1 and Viva 2. And a score of total of more than 24 is required to pass the exam. And at least 2 components with more than 6 score is needed to pass the examination. So these are the scoring charts that have been provided in the RCR website. This is for the rapids, wherein you get +2 for a correctly identified normal image and a correctly classified and correctly identified abnormal image. They say that incorrectly classified, but with an appropriate false positive is also +2, which I doubt because there is mostly a +1 here. That's why we get 49 and 53s out of 60s. So if you just look at this chart, so with 30 rapids, you would want to get at least 27 right, which would make the score of 54 with +2, and that would make you an overall mark of 6. And beyond that, the score keeps on increasing up to a maximum of 8. In long cases, again, you would be marked out of 8, wherein you would get a score of 3 if you do not offer any answer. So that's suicidal. Out of 6 cases, you have to attempt all the subheadings of all the 6 cases. To get an 8, you need a perfect answer, clear and confident on each of the cases so that your score is more than 46.5 to get a score of 8 out of all the 6 cases put together. So if you see that if you are managing a pass or a good pass in all of the cases, that can make you easily score above 40 out of the 6 cases. So you can easily get more than 6.5 up to 7.5. That would be the logical expectation out from yourself. Then the third part of the examination, that is a Viva, wherein again you would be score out of 8 with the minimum score of 4, which is a very poor answer. That is, key findings are missed even with help. It's a wrong or a dangerous diagnosis. Next comes a score of 5, that is a poor answer, that is slow to spot the abnormality, a poor differential diagnosis, needed help to get the correct answer. A score of 6 with some abnormalities seen with help, principal diagnosis being right, and limited differential. So I'm emphasizing on these facts just to make you feel comfortable that scoring a 6 only means that you have picked some abnormalities with help. A principal diagnosis is right, and you've provided with limited differential. That's not much to ask from yourself, right? Next would be a good answer wherein you have spotted all the abnormalities quickly, a correct deduction made and a correct diagnosis made, and a good differential is offered. And an excellent answer would make it to a score of 8. So let's just talk about a few tips and tricks which would help you in your examination. This would include the first thing that I would bring to your notice would be that this is not an examination just to check your radiology. They've already done that in the part 1 and part 2A of the examination. What they are hoping from this part of the examination is how confident you are, number one. How would you deal a colleague who would come in the reporting room to take your opinion about any given case? and how well you can manage a patient in your day-to-day practice. So in addition to radiology, you would need the right state of the mind, and in my opinion, the state of the mind plays much bigger role than your radiological knowledge. So you need to be calm, composed, and confident before, during, and after the examination. So let's do the math. You need 24, and if you can score 8 in any of the four components, let it be rapids, Viva, or long cases, you're very likely to pass the examination because the minimum score in each component is 4. So you get 12 in the other three by default, and you have already scored a 8 in one. So that makes it to a total of 20 without even attempting the rest of the examination. Next come, there are days of the examination. There is a day one wherein you would be attempting rapids and long cases. My suggestion would be try and aim for a 14 or above. If you're able to do that, that makes the examination a cakewalk. Suppose you realize that you've not done well in the day one, still half battle is remaining. Do not get disheartened. Do not think that you've already failed the examination. I know of people who have scored less than 6 in both the parts, but they have cleared the 2B examination based on the Viva examination. As we all know, Viva would be the most difficult part of the examination to plan. So do not take much stress of it, but do keep practicing. That would be your way to go about it. Remember the keywords. You need to be safe radiologist. You need to highlight the emergency conditions so as to show the examiner that you are a safe radiologist. So let us talk about tips and tricks about each of these segments. In rapids, there would be 35 minutes for 30 cases. Only single abnormality or a single recognized fracture complex would be given. So if you're seeing something which is more than one or unrelated to each other, be sure that it is something wrong that you're seeing in either of those two that you have spotted till now. This happened with one of my colleagues. He had marked the pneumothorax once, and then after 2-3 radiographs, he actually saw a pneumothorax. So he was quite sure that the one which he had actually called as a pneumothorax before was actually not one, what was a normal radiograph. It would be usually the routine A&E or a GP pile that we usually see every day. Out of the total number, 40 to 60% are bound to be abnormals. That is, the usual score would be between 12 to 18. And these days, what we are usually seeing, it is usually between 14 to 16. Therefore, you can keep a magic figure of 15 in your mind. Suppose you have already found out 15 abnormal radiographs. You should cool down yourself. That means you're likely to pass, because even if you marked 3 wrong, then also you're likely to pass the examination. Pass mark is usually 27. The abnormality would be obvious. It will be an unambiguous finding. All the ambiguous radiographs are removed from the examination. There's a very strict criteria for the radiograph to come into as a part of an examination. And please do not overcall. It is overcalling which people usually do and fail in the examination. One more important thing is, do not carry the stress or excitement of the performance in the long cases to this section of the examination. You would start with long cases, there'll be a 5-10 minutes break, and then you move on to the rapids. You need a clear state of mind to ace the rapids. So even if you've done the long cases very nicely or bad in the other case, do not carry this to the rapids. Next advice would be to get accustomed to practice software. Not many people do that. And I think that's not something that you should be doing, because there are specific shortcuts in the practice which you should be well versed with. That saves a lot of time. You should not be going to the top of the screen and then pan or zoom or alter the window or reset it. That should be on your tips, onto your fingers, without wasting any single time. So become efficient in the practice software. There's an option of flagging the image. Utilize it very appropriately. How you can do that, I'll just tell you how I did it in my exam. That's not the only way to do it, but that's what I did, and I found it to be useful. And remember, you're likely to have one pneumo in your examination. So if you have not found one, please review your abdominal or chest radiographs once more. So how I did it before the exam was, I usually did 1 to 3 sets every day till the day of examination. I did not start the exam preparation long before. I only started once I got the slot in late January. And that's how I got to know about the Teams group as well. So unfortunately, I could not volunteer as a as a attend. What I could just do was observe the people who were presenting their vivas. My recommendation would be to use a website which has a platform similar to Practique, be it RAD exams or Revise Radiology. I know of these two, there may be others as well. How they help you is because you get used to the shortcuts, and that helped me a lot in my examination. Always try the free set before purchasing, because some websites do not have a friendly software, and I kind of was not comfortable using them. RAD exams is definitely the cheaper one, which provides you with 60 sets in 60 pounds for a subscription of 6 months. Revise Radiology, which I have not used, it's slightly expensive, but people say it's good. For RAD exams, you can use this code. This would give you £5 discount, and then you can share the codes of your own so as to get the benefit and get accustomed to the shortcut is what I would want you to focus on. On the day of examination, how I did was I started with the first round, identified the absolutely grossly abnormal radiographs, and write the answer completely, including the site, the location, and the exact description of the fracture. In the first round, I would not spend much time on the apparently normal radiographs. I would just flag them, and I would aim to finish this round in around 10 minutes, because there'll be around 15 abnormals maximum that I would pick up in this round. Next is to count the abnormal radiographs that you've already done, and this would increase your confidence. Suppose you've already got 14, you know that you are very close to passing the examination already. So that increases your confidence, increases your attention span to the forthcoming apparently normal radiographs. Second round, spend more time on all the normal, identify the subtle abnormals, and try to finish this by around 30 minutes of the examination. So that would leave you with another 5 minutes. Just go through the description of abnormal radiographs again, so as to make sure you have not written right or left or humerus, femur interchangeably, which can happen in the stress of the examination. So be sure of the site, and the name of the bone correctly. These are some cuttings which I got from the examiner's report, because there are a lot of questions how to write the answer in the rapid, what gives you a perfect 2 or a 1 or a 1.5, depending on the examiners. So these are the statements made by the examiners themselves. Identifying a fracture but failing to identify that this is a pathological fracture, this would not give you a complete mark. This would only give you half a mark. So if it is a pathological fracture, you need to state that also, that is a fracture through the simple bone cyst. Identifying a fracture but failing to accurately describe its anatomical position, that is from the base of a fifth metacarpal. If you've just written it as a fracture or a loosened line through the metatarsal or a fracture through the metatarsal, that would not give you the entire complete 2 marks. What can give you just half a mark would be fracture fifth metatarsal or fracture metatarsal base. To gain a full mark, you need to write down a transverse fracture base of fifth metatarsal or fracture base of fifth metatarsal. So you need to be very specific with your description, and only when it is complete, you would get the complete 2 marks. Again, identifying a single fracture in a well-recognized fracture complex, where a second fracture would be expected, would again give you half a mark only. That is, if there is a paired bone like radius and ulna or tibia and fibula. So if you're seeing the paired fractures, you need to mention both of them. Or else in a ring structure like a mandible or pelvis, you again need to mention both the fractures together. Next is identifying an abnormality, but failing to accurately localize it. That is, you have identified that there's a mediastinal mass, but you're not calling it accurately as posterior or anterior. Similarly, with the renal tract calculus, you've just written it as a renal tract calculus and not labeling it properly as either a ureteric or a renal, would not fetch you the complete set of marks. In long cases, 75 minutes for 6 cases, you need to keep 10 to 12 minutes for each case. Typing is the key. You need to be very fast in typing. For those of you who are not, please start practicing from now itself, because you know a lot of many things, but if you cannot convey it to the examiner, that makes no sense. Each case has to be attempted in 5 subheadings, that is observation, interpretation, diagnosis, differential diagnosis, and management. Use bullet points. Nobody wants to read your paragraphs. That takes more time, and it is not nice for the examiner also to go through that. So please ignore that. Only use bullet points. It, I believe, is the easiest section to pass. I've never heard a person failing in long cases. So what you need to do is try and score higher on this, like at least a 7 or at least a 6.5. That would help you compensate for the other parts of the examination. You have to attempt all the subheadings of all the 6 cases. Even if you know nothing about it, write down whatever you can see it. You will at least know that it is an X-ray or a CT. Whatever finding you are seeing, write down a logical differential diagnosis, and a management step. Anything would written would fetch you at least 4, 5, or even more marks. Find the abnormality, look for the relevant positives and negatives, correlate between multiple findings. See, in examination setup, you are likely to get a case which has multiple findings, all correlating to give you a unifying diagnosis. Such things not happen frequently in routine practice, but they are much more commoner in an examination day. So if you've spotted a significant finding, start looking at the relevant positives, relevant negatives, correlate multiple findings to fit onto a given diagnosis. One case is usually given from each systems, that is of the 6 subheadings, that is GI, GU, MSK, PEACH, CNS, and chest. In the management part, go beyond the MDT referral. Nowadays, everybody is writing MDT referral. You should write down what would you advise as a radiologist in the given MDT. Remember the regional bone tumor unit. We do not have that in India. I hope many other places do not have that. In UK, they're very specific about it. Any bone tumor case gets referred to a regional bone tumor unit. You do not biopsy by yourself. You do not treat by yourself. You just refer it to the regional bone tumor unit. So be specific about what you would be doing next. Highlight the emergencies, call the ER team, pick up the phone, show the level of urgency that you have so as to save the patient, and be careful about the patient. Only logical investigation needs to be asked for. I've seen multiple Vivas in which people keep on saying, I'll do a bone scan, I'll do a PET CT, I'll do this also, I'll do that also. But no, the healthcare there in UK is free. It comes under the NHS. The government pays for it. They cannot keep on doing all the irrelevant, unnecessary investigations. You have to be very specific. You have to be very logical in that. There are few websites for long cases, that is FRCR long cases and revised radiology. I didn't subscribe to either, but I've heard that these two are good. So just to give you a perspective, if any one of you can unmute yourself and tell me what the diagnosis is, or how would you write this as a long case? Any one of the volunteers.
Dr. Sahar, can you go?
Yeah, sure. So in my findings, it is just radiogram. So there are areas of interstitial thickening with kinase is seen in the right lung, both lower lobes, with decencies in the right upper lobe. Chest X-ray, there is evidence of decency, that means it is pneumothorax. There is no pleural effusion. CT chest lung window. Findings are bilateral, irregularly outlined, seen in both lungs, upper zones, with no obvious discrete necrotic nodules. There is evidence of right-sided pneumothorax. So my interpretation with these pneumothorax and multiple cysts with no nodules, principal diagnosis is lymphangioliomyomatosis. And since it has association with tuberous sclerosis, so I would look into the other stigmatas of the disease. Differential will include Langerhans cell histiocytosis. I would review the prior images and would refer the patient to pulmonology and further screen out the patient for population of findings like abdominal ultrasound for angiomyolipomas and CT brain or MRI for further associated findings.
Perfect, Dr. Sahar. So there's no perfect answer for a long case. But why I showed you this case was just to make sure, to help you as to how the examiners would mark this case as. They usually provide it with a marking scheme. And this is just a sample. This is not the perfect marking scheme, but this is just a sample marking scheme wherein a candidate would get 4 if he gives an unlikely diagnosis of either cystic metastasis or bronchiectasis. To score 6, you just need to come to a principal diagnosis of cystic lung disease with the differentials of LAM and LCH, talk about the possible associations with NF and tuberous sclerosis, describe retained lung volumes, and identifies pneumothorax on CT. So just a few suggestions to what you have already told. is you did not highlight the pneumothorax much. You have to show a sense of urgency for that. The patient needs an urgent referral for the same. Next is you have to talk about retained lung volumes, because any chest case which is showing an interstitial lung pattern, the next thing that should come to your mind is whether the lung volumes are retained or not, because then your differential start. For the retained lung volumes, you would talk about these cystic lung diseases. And for those with reduced lung volumes, you start thinking on IPF and the sarcoidosis and all the others. To get a 7 or 8, they would list a few interesting findings on the scan, and they would want you to get a significant number of them for you to get 8, and most of them for you to get a 7. For example, in this case, if you give a good chest X-ray description of retained lung volumes and interstitial markings, a good CT description of cyst with own walls, uniform size, no nodules in a female, bilateral effusions which are seen on the radiograph as well as on the CT scan, talking whether they could be chylous in nature because we are likely dealing with a lamb, thoracic duct clip if you've spotted that because the patient would have been treated to reduce the chylous effusions, talking about the pneumothorax, referral to the respiratory team, possible open lung biopsy, and talking about smoking history for LCH. So if you do majority of these, you would get an 8 on 8. If you do most of these, you will get a 7 on 8. But the most important point is, if you have to just pass the examination, you just need to come to a principal diagnosis of cystic lung disease, talk about retained lung volumes, and identify the pneumothorax. It's as simple as that. So if just written only 6-7 sentences in your entire case, you could get a 6 mark. So even if you're running short of time, please focus on the important things, just mention them, fill in all the subheadings, and you would get a 6. Next is Viva. It is all about mindset. Try treating it as a discussion with your own colleague. You will not know the diagnosis in all the cases. Do I know all the diagnoses that I was shown? No, I don't. So it is quite possible that you would not know all the diagnosis. What they check is your approach. Verbalize. A long pause is unacceptable. I've seen many Vivas wherein the candidate would just keep on scrolling through the images, will not tell the examiner what he or she is thinking about. So that would, even if you're thinking the right things, they don't know it, right? So you have to verbalize whatever you are thinking, whatever you're doing, keep talking, keep talking. Next, one thing which I find very irritating is the candidate starts looking at the scan and starts speaking as all the things that he or she is seeing. Like he would first spot a liver cyst, he would say about that. He'll then talk about cholelithiasis. Then he will talk about some pancreatic calcification, then some atrophic spleen, and then finally come on to the main thing, whichever the diagnosis is, like a renal cell carcinoma or something. So just think it from the perspective of the examiner. They are examining at least 8 to 9 candidates every day and listening to all those things again and again and over and again. So you have to be very specific. Start with introducing the modality, the phase, and the quality of the scan. Then start with the most relevant finding. You can take a few seconds to scroll through the images, identify the most relevant finding, and then start verbalizing, rather than just talking whatever you're seeing as the first finding in the scan. Then talk about the relevant positives, relevant negatives. The examiner knows that you know your subject then. He knows that you have a logical step-by-step approach to a case. Talk about the diagnosis, associated findings, differential diagnosis, and then management of the case. Most important thing which I realized attending all these Viva sessions was the ability to close a case or not able to close a case. Many candidates who are not able to close a case would keep on struggling with the case and they will not move on to the next case. So whether you know the diagnosis or you don't know the diagnosis, you should know how to close a case. You should be able to verbalize your findings, come to a conclusion, close a case, and then look at the examiner so that he or she knows that you've already done whatever you wanted to convey to them, and they can then come up with their suggestions, their questions, whatever it is. Next is show urgency for emergency cases, previous imaging if it is relevant, and orthogonal views in a case of a radiograph. Always intermittently keep looking into the eyes of the examiner because they're also humans. They will give, they're not allowed to give you clues, but they'll eventually land up giving you some or the other clues. And once in a while, it is okay to say, I'm not able to think any further, and suggest a relevant next step, because there's no point wasting on a case which you have already, which you think you're not able to come to a proper diagnosis. A few more tips: get used to the team software by Microsoft. That is the one which would be used there. Do not fiddle with the screen unless you're asked to do so, because I've seen people start using the mouse themselves. They do not appreciate that. Do not do that. They'll ask you when you have to touch the mouse and when you have to start scrolling. Next, every one of us suffers from the scrolling method, and this is the most irritating part of a virtual Vivas. But the tips would be: wait for a few seconds for the case to load. Once the case has loaded, click on the image and then you can start scrolling. There are three alternatives to scrolling. One is using the arrows, that is the right and the left arrows of the keyboard, not the up and down. Be careful of it, the right and the left arrows, not the up and down. There would be a bar on the screen which you could scroll through using the mouse, or the center scroll bar in the mouse. So all the examiners say that you should prefer the arrows in the keyboard, and that's what I have also realized, that most of the candidates say that it is the most friendly way of scrolling. So start practicing with that. Start practicing with the arrows right and left. Attend as many mock Vivas, practice sessions or sessions by Dr. John Curtis as you can. Try attending a FRCR 2B course if you have that in your own geographic location, or you can attend a virtual one. I know that they are expensive ones, but it gives you a feel of the examination, and I feel it helped me a lot. If you are not able to present in the mock Vivas, like I was not able to do that, but do keep attending them as an observer, because it helps you learn from the others' mistake. And at the end of everything, please remember, it's just an examination. It is nothing more than that. You're not going to lose anything if you do not clear the examination. Hopefully it will not happen that way, but even if it happened that way, there's nothing beyond that. So there'll be always a next time. So keep your spirit high, and I think if you can just be confident and focused, you'll be definitely able to clear it. So if there are any questions, I'll be happy to take them. If not, we'll move on to the Viva part of the examination session today. So I don't see any questions on the chat as of now. So we'll move on to the Viva. And if there are any questions in between also, you can keep texting me as a personal message, and I'll hopefully take them, as many as I can. So the first candidate, if you're okay, you could unmute yourself and tell me your name.
Yeah. Hi, Dr. Ankit. First of all, congratulations for such a great success.
Thank you.
For giving us such a nice presentation and deep insight into the exam. I'm Dr. Sahar. So I'll be presenting this first case. This is a frontal chest radiograph of a skeletally mature patient. There is a striking abnormality. I can see that I cannot visualize the right heart borders on this radiograph with some infrahilar increased bronchovascular markings. The orientation of the limbs on the frontal radiograph seems to be forming kind of a sudden appearance on the frontal radiograph. I'm going to review my other areas. So visualized lungs appears unremarkable with no obvious collapse, opacification, or consolidation. There is no pneumothorax. There is no pleural effusion. And the visualized rib, apart from the orientation of the ribs, are unremarkable. If the patient is already in the department, I would go and clinically examine patient because I'm suspecting pectus excavatum. If patient is already, or if possible, I'll review the lateral radiograph. Also, in view of the presentation of the front radiograph, if there is prior radiograph available in the system, I'll review them. So in view of all these findings, my prime diagnosis is pectus excavatum with no other associated abnormality. I would refer my findings to the referring physician and pulmonology as well. And sometimes they measure these post-external diameter in these patients because of the reduced diameter. Patient, those who are athletic or involved in exercise, they have some issues with cardiac stress test or something like that. They cannot take strenuous exercise. So we have to convey these findings to, I think, pulmonology as well as cardiology.
Okay, so you said that you would examine the patient if the patient is still with you. Unfortunately, the patient has already left. So what would be your next step? The patient has already left the department. What would you do next?
So that's, I will, if in my system, patient is already has radiographs and later radiograph has taken, I will review that and then confirm my findings based on those.
And if the
But
lateral
otherwise,
radiograph is, if the lateral radiograph is not available to you, would you just call the patient back and get it done?
then since this, if no, not likely. I will flag my findings to the, if patient is through as an outpatient as a referral GP, I will convey my findings to the outpatient GP referring physician to examine the patient. And if needed, we will do the radio later. Usually they are not done.
Okay, great. This is your next case.
So this is a X-ray pelvis frontal projection. So the most striking abnormality is I see that there is an increased sclerosis seen along the left iliopectaneal line as well as the ilioischial line with slight broadened trabeculations and bony expansion. In view of the age of the mature and skeletally mature patient, my prime diagnosis is Paget's disease. However, I'm going to review the rest of the bones for any lytic or sclerotic lesions. So right iliac bone and rest of the femori and right ischium appears unremarkable. There is no osteolytic lesion. Visualized soft tissues appears unremarkable. Based on my finding, my prime differential is Paget's disease. Again, this case, the patient is already a known case. I will review the prior images, look at the labs for the bone turnover like alkaline phosphatase, and refer the findings to the referring physician, orthopedic, and further evaluate the patient with a bone scan if needed by the clinician.
So this was a 70-year-old gentleman who had presented with fall and left-sided hip pain.
Since I cannot appreciate any fracture on this X-ray, so in this case, if there is some subtle X-ray, I would go for CT to evaluate for further bony elements or the fracture.
Okay. So this is another patient.
Yeah,
what are your
this is
thoughts?
so this is the vein scan of some other patient, not the one that was presented earlier. So in this patient, I can see there is a diffuse uptake seen in the left femur involving the metaphyseal as well as the diaphyseal region. And there is a diffuse uptake seen in the iliopectaneal as well as the ilioischial line. There are some uptake seen in the vertebrae and as well as the right distal femur that can be related to some fixature, not exactly to the bony pathology. So again, my findings in this case is most likely the uptake, especially in the left renal as well as the left pelvis, is of Paget's disease.
Okay, so what do you do next?
So is this patient presenting with acute pain? So
No, the
I would
patient
put
has no acute pain, no
no
acute
acute,
symptoms.
no acute symptoms. So I will, in this patient, since the bone scan is available to me, so I will correlate my findings with the plain or conventional radiograph to further confirm my findings.
Okay.
And also review the prior images.
Okay. So do you have the remote control? I don't think. Can you ask for one, please?
Yeah, I will ask for. Yeah, I asked already.
Yes, please go ahead. So this is an 80-year-old female who was presented with abdominal pain and distension. She was initially managed conservatively, but she's having worsening pain. So you could please move on to the next. So this was the initial chest radiograph that was done.
Okay. And it was presented with abdominal pain and distension, 80-year-old female. And now it is aggravating more. So this is a frontal chest radiograph where I can see the increased interstitial markings in both lungs. There are some area of bony sclerosis that I see in both humeri that they are very well defined, and I would need, uh, since I just need to explore my review areas. Reviewing both lung fields, I don't see any focal lung lesion. There is retrocardiac area appears unremarkable. Soft tissues appears normal. So I cannot find any obvious reason for her abdominal pain and distension on this frontal chest radiograph, except for
So
these
what?
well-defined sclerotic lesions that can be a benign thing also,
So
like osteoporosis. Yes.
the sclerotic lesions were found to be not contributory, so you could please ignore them. You
So I
said
would
that.
try.
So you
Yes.
said that you did not find anything relevant as regards to the abdominal pain. What were
Yes.
you looking at on a chest
Actually, I'm
radiograph?
looking for the air under the dome of diaphragm, but the air that is under the left dome of diaphragm looks like to be a stomach bubble. So I would
Okay.
definitely review the abdominal
So
X-ray.
this was the abdominal radiograph of the same patient.
So abdominal radiograph of the same patient presenting with abdominal pain and distension. Uh, um, the likely abnormality which I can perceive in this radiograph, there is some lucency seen in the subhepatic region. And there are few minimally distended loops seen in the right hemipelvis, but there is some, I'm not sure, but there may be some associated soft tissue abnormality. However, I don't see any crossly distended bowel loop. There are fecal loading of the large bowel. I'm just going to review if I can see some bony abnormality like the pedicles and any sclerotic or lytic lesions in the visualized bones, which unfortunately I am not able to appreciate. So the
Okay.
more
So what would you do next?
I would definitely go for the contrast and NCT abdomen for further evaluation.
So here it is. If you could scroll through the images and let me know of your opinion, please.
Yeah, yeah, yeah. First, I'll just get used to scrolling, then I'll start. Sorry. Oh my God.
No issues. I'll just move back. One second,
Yeah,
please let off the mouse.
yeah, I let off the mouse. Yeah,
Yes, you can go.
yeah. So this is the CT abdomen of the patient already reviewed the abdominal X-ray. So I'm scrolling cranial to caudal. The visualized lung basis, I don't see any pleural effusion or any solid pulmonary nodule. There is evidence of hiatus hernia. There is a moderate amount of ascitic fluid seen around the liver. I'm trying to go to the pertinent finding that is relevant to patient's history. So there are multiple dilated small bowel loops with reduced enhancement seen in the left side of the abdomen. Overall, the bowels there showed reduced wall enhancement. And there are some, so in this elderly patient, my prime concern is about the ischemia. I'm just going to look back into the vascular supply.
Yes.
And it's just to go back. There's some specks of hair or air also I saw in the left lower abdomen. And these are the gross atherosclerotic changes seen in the aorta. There is a speck of air in the portal system as well and in the left side of the liver. So in view of these findings, my suspicion is of the ischemic bowel loop with portal gas, reduced enhancement. I can see some foci of air in collapsed IVC as well.
Could you please show me that?
Oh, hold on. No, IVC is collapse. Actually, this is the portal system, which I can see. This is a portal vein where I can see the specks of air.
Okay. So what would you do next?
So this is the emergency because of the diffuse reduced enhancement of the bowel enhancement pattern with the portal gas, especially in the elderly. So my high suspicion is ischemic bowel loop. I'll urgently call the referring physician and surgery on call for the emergency of the case in view of the ischemia of the bowel.
So suppose I am the surgeon on call. You give me a ring and you say that there's an ischemic bowel disease. My next question would be to you: do you find the cause, doctor?
Actually, this is what I was reviewing, and I'm not able to find any arterial thrombosis or any venous thrombosis in the clarity, though this is a diffuse atherosclerotic changes in an elderly female. So for the intervention purposes, I'm not able to localize any area of thrombosis, but definitely I will review again.
Okay, you could please let go of the mouse. We'll move on to the next case. So here it is. First, look at this stationary image, and then if we feel the need, you could then later on scroll through.
Okay, so this is the lateral soft tissue radiograph of the neck, where I can see there is a canalization of left parotid duct, where I can see the contrast going through the left extensors duct, with some areas of, in the periphery, there are some areas of circulation or dilatation. So since I don't have a control film, so I cannot comment of any radio opaque calculus. However, there is no filling defect to suggest so. So in view of the single static image, this is the left cyelogram of the left parotid gland, where I can see there are multiple tiny focal dilatation suggestive of cylolactasis. However, if I have another series of images, I will definitely refer to further.
You could please scroll through the images. Yes.
Yes, so starting it's from here, from the, yeah, no, I'll go come now. So there is a cannulation of the left parotid Stenson's duct. So there is an opacification, and I don't see, there is some outpouching of the contrast seen initially in the proximal part of the duct. So, and then I see this contrast filling up more, and it is going down. So there is some leak or perforation in the proximal part of the left Stenson's duct. So I retrieve back or withdraw from my initial findings, which I gave on the static image.
That was found to be normal. So you could please ignore that.
Okay.
So how would you want to tell this patient, and how would you want to manage it further then?
Based on the initial filings of that tiny beaded outpouchings, and I think this contrast is actually leaking at the time of the cannulation. So I would rather do an ultrasound if the patient is still there. I will correlate my findings with the ultrasound and see the findings correlate with my fluoroscopic findings. So I will then finalize my diagnosis based on ultrasound.
Ultrasound was done, and it showed dilated parotid ductules on the left parotid gland. There were a few debris within, and there were no calculi found on the ultrasound.
So, since they initially when we were cannulating and the contrast was leaking, so it means that there is some kind of obstruction distally. That's why initially in the proximal portion, the contrast was leaking down. So maybe there is some, if the ultrasound is not giving any silolithiasis, so maybe there is some structure of the Stenson's duct that is leading to the debris and all these findings on ultrasound. I would correlate my finding with the patient history and labs, and then if needed, I will relay these findings to the referring physician. But frankly
this
speaking, based, yes.
yes, so this was a young gentleman who had presented with dry mouth and dry eyes.
Okay, then my prime diagnosis is Sjogren's disease based on the history of this gentleman.
So do you see anything on imaging to support that diagnosis? Or
Really,
if that,
on the fluoroscopy, I cannot comment very well, but on ultrasound, if I see a patient with Sjogren's
okay,
disease, I will see a
fair enough.
bilateral collaterals with say cyst in it.
Fair enough. You can look at your next case.
So this is the hand radiograph where I can see that there is area, and the second middle finger, I can see a mark soft tissue swelling with the overlying eccentric erosions of the middle and as well as the proximal phalanx. The rest of the bones and the joints appears unremarkable. There is no soft tissue swelling. There is no soft tissue swelling of the rest of the fingers. The visualized carpal bones appears unremarkable. So I'll come back to the prime pathology. There is a marked soft tissue swelling with no apparent calcifications. With underlying bony changes, my prime diagnosis is gout. I would review the prior imaging of the patient and as well as other joint radiograph if available, and relay my findings to the referring physician for further evaluation of my clinical findings.
So how would you evaluate further in addition to informing the referring physician about the same?
Like if the patient is presenting with the elbow pain, then I can look at for the oligoclonal bursitis.
No, you just presented with
Gout, I will
the...
review the labs for the uric acid, hyperuricemia.
Okay, so I think your time is almost up. I'll just spend a few minutes on giving you the feedback. Dr. Saha, you did really well. You know your subject. You just need to polish yourself a bit more, in the sense that you could easily score an 8 on 8 because you know almost all the diagnoses, you know what you're talking about. It's just how you present it to the examiner in a given period of time and try and close the case as soon as possible. In this first case, you said that it is a frontal radiograph of a skeletally mature patient. Okay, so whether the patient is skeletally mature or immature has an implication if you're dealing with an MSK case, right? You, after seeing the image, know that this is a case of a pectus excavatum, if not a right middle lobe collapse. So try and change your wordings depending on what case you are seeing. So in this case, you could just have said that this is a frontal radiograph of an adult patient. And suppose you're seeing the breast shadows, you could say an adult female patient. If not, you can say an adult male patient. So try making that variation in your presentation so that, because see, as I said, the examiner would be listening to the same thing again and again. So they need to find a variety in your answers so as to appreciate it. That is the first thing. Next, you referred this patient again to the clinician. This patient mostly would have been a known case of pectus excavatum. This would have presented with some other symptoms, and the radiograph is showing an incidental finding most likely. So talking about the terms, like you even went on saying that I would flag the case. You only flag the emergency cases and not the routine or the normal variants. So just be a bit more careful with your words. Otherwise, you did very nicely. You talked about all the relevant imaging findings. That is the obscuration of the right heart border, the shift of the mediastinum towards left, oblique oriented ribs. When you are describing a sign, for example, as you said that there are 7 shaped ribs, before talking about the word 7, describe the finding first, because you should say that the anterior ends of the ribs are obliquely oriented, giving an appearance of the number 7.
Yes, I could have done that.
So that makes it much better. And once you've known that you're on the right track, you've come with a diagnosis, Move on to the diagnosis, say that there are no other differentials, and you would just review as to why was this radiograph done. If it was as a part of workup, I would just make a note of the findings, and nothing needs to be done further. If there's a prior imaging, I would just look at the prior imaging so as to be confirmed about my findings. The examiners would tempt you towards doing a lateral radiograph. Please do not say that, because that's an additional burden, additional radiation. So that's why I specifically asked you, if the patient is not there, would you call and do a lateral radiograph? Say no. Lateral radiographs are not needed. They're unnecessary radiation exposure to the patient. Okay. So once you know what you're talking about, stand by it, because sometimes the examiners would just want you to check as to what you do as the next step. Same in this case. The moment you saw the radiograph, you knew the diagnosis, that it is a Pagets disease of bone, right? So in this case, what you did was you talked about the iliopectineal line thickening, the coarsening of the trabeculae, and then directly came on to the diagnosis of Pagets disease. So whenever you get such a case wherein you are very sure of the diagnosis, describe it properly. As in, you should have told that there is a bony expansion, cortical thickening, trabecular thickening, involving the left side of the pelvis. The left femur looks okay. The rest of the skeletal is okay. There are no pathological fractures. There are no obvious cortical destructive lesions. So as to talk about all the relevant positives and the relevant negatives. So once you know in your mind that this is a case of Pagets disease, rather than verbalizing the diagnosis first, talk about the relevant negatives. Tell the examiner that you're looking for a pathological fracture, which you don't see any. You're trying to look for any neoplastic process, which could be a complication of Pagets disease, which you don't see any. And then again, talk about why as to the patient would have presented. And then the relevant next step, which you did very well in this case. You talked about the bone scan and the lab parameters. That was perfect. Next case was again a Pagets disease of the bone that was kept so as to just give a feel that nuclear scans do come. And again, you knew the diagnosis. It's just polishing your way of presenting it. You could say that these are the planar images of bone scan in anterior and posterior projections. We tend to get confused with the rights and lefts. So you could just talk about the rights thing first and then the left, or whatever. The most striking abnormality, as in this case, would be the left femur. So talk about the left femur, start with the characteristic finding first. That is, it starts from the epiphysis and goes on up to a varying length in the diaphysis. Next, talk about the cortical expansion. See, every disease would have certain buzzwords. So talk about the cortical expansion. This is a bone scan, but you're still viewing the anatomy very nicely. So that's an indirect sign that this is a Pagets disease. Third, talk about the cortical thickening. Talk about areas of multifocal uptake. Again, in right iliac bone, you see that there's a cortical thickening. Again, well appreciation of the anatomy, involvement of the bones. And then talk about whether there are any obvious focal areas of uptake to suggest a neoplastic process of the pathological fracture, which you don't see any. And then again, once you've been provided with the bone scan, you just said that this is a Pagets disease, and that's it. So that should not have been done. You should always say, see, the anatomical visualization on a nuclear scan is very poor. So you should always say that you would correlate with the radiograph next. Whatever bone scan you are provided with, no matter how sure you are of the diagnosis, always correlate with the radiograph first. So always say that in my routine daily practice, I would correlate with the radiograph so as to be sure of my findings, and then convey that these findings are likely to suggest of Pagets disease. Once you've come to a diagnosis, talk about the next management steps, and then give it a pause. Next thing that you did in this case was you did say about the radiograph, but that was almost towards the end of the examination after my repeated questioning. So that should have come much earlier, number one. Second, you asked me if the patient has presented with pain or something. So instead, you say that if the patient has presented with pain, I would do this, or I would look for this, rather than asking the examiner as to what this patient has presented with. So think of a logical presentation, and then you yourself verbalize it. If the patient has presented with fever, I would do this, this, this. If the patient has presented with fall, I would do this, this, this. So that would make let the examiner know that you know about your stuff, and they don't want to be questioned. Like they would not want you to answer your questions. Next, this case, again, you knew the diagnosis the moment you saw the case. So first thing is, such radiographs might come in an examination wherein you see nothing at the first instance. So this was the first time in the Viva where you actually got blank for a few seconds. So that's okay to do that. But once you've realized that you're not getting to the finding, so have confidence, because you've already picked up 3 relevant findings, right? So you should know that you will not miss a very simple finding. So start looking at your review areas. The most important thing was, this was the first time when you were provided with a history. All the previous cases, the examiner did not give you the history. So if the history is being provided only intermittently, that means the examiner wants you to know the history very carefully. And the problem in the examination is, once you've heard the history, what happens is, after some time, you tend to forget the history by the time you are into the case. And then you would think what the history was, and then you start questioning the examiner. So if the history is provided, keep that on one side in your mind all the time, so that whatever you're looking, you should know that the history was this, because whatever the examiner says has some value to it. So in this, the examiner had said you that the patient is presented with abdominal distension. So after looking at the radiograph, first thing that you should have told is there's no pneumoperitoneum. And then talked about the rest of the radiograph. You did talk about pneumoperitoneum. It slightly came later on the part of the description. Next, again, you were very spot on in this radiograph. You talked about the pneumo, you talked about the bowel dilatation, you talked about other relevant findings. And sometimes in the examination, it is possible the examiner gives you a normal radiograph, so as to look as to what you would do next, because the history is significant and the radiograph is normal. You rightly said that you would go on to CT. And this was the CT that was provided. I think you could have done better, seeing what you did in the other parts of the examination. You should be slightly quicker in picking up the relevant important findings of pneumo, porta, and the decreased enhancement of the vessels. Once you've looked at the vessel enhancement and you know that it's an ischemic bowel, you say that I'm looking at the superior mesenteric artery, trying to figure out if there's only atherosclerotic narrowing or there are some filling defects. I do realize that this is a venous phase of imaging. I would look at the arterial phase. That would have given me a better picture, so that the examiner knows what you are going to do next step in your daily practice.
Yes.
Second suggestion to you would be, again, you started with hiatus hernia, the lung fields being normal. Please take a few seconds, tell the examiner, I'm just going through the provided sections for a few seconds. I'll look into the pertinent findings and then start commenting. It's absolutely okay to say that much. And while you're saying this, you would have already scrolled it once. So next, you know that, yeah, it's an ischemic bowel. Talk about the bowel enhancement, talk about the pneumoporta, talk about the the gas within the superior mesenteric vein, talk about the arteries, talk about the ascites. If till then the examiner has not told you anything, then move on to the additional findings of adrenal lesion or yeah, that's all. So that's how you would convey it to the examiner, come to a diagnosis, say that there are no absolute differentials for this case. This is an emergency. You would ring up the surgeon on call, inform your findings, and the patient might need an urgent laparotomy. So once you've said that, look into the eyes of the examiner. Again, in this case, you started spot on, you picked up the abnormality, you were going perfect, you earned for the rest of the study. That's why I told you, you first comment on the study, and then if we feel the need, you will be provided with the next images. And you absolutely did that. You told about all the positive findings in the study. So you were provided with the next. So this thing you should remember. Sometimes what happens is you're provided with an ultrasound and you just say 1 or 2 lines and then you say, I would do a CT scan. So that's totally not acceptable. Once you're provided with an investigation, you have to complete that investigation, because that will be marked as a separate event. Once you've done that, only then move on to the next investigation, and you will be provided with the next only once you have earned that investigation. So you actually earned the investigation, and then you kind of lost the track. So this was a patient with Sjogren syndrome, wherein you see dilated ducts with a few ectasias here and there from the parotid ductules. There are few filling defects, which I do agree are difficult to appreciate on this small image, but there are the debris within. And then rightly you said that you would look at the control image. So that is the second thing. That's why I kept the post opacified radiograph as the first. That's how you will be usually provided in the examination also. So then you should ask that if I would look at the control radiograph, that there are no radiopaque calculi, there were none, and then talk about the diagnosis. Once you've talked about the Sjogren syndrome, do a rheumatology referral, close the case, and move on to the next one. This was again gout. Here, you did not talk about the buzzwords. You did not talk about the overhanging edges. You did not talk about the sclerotic margins. Again, you knew the diagnosis the moment you saw the radiograph. So once you've seen that, talk about you did talk about the tophi, you did talk about the hyperdensity within the tophi, but the osseous changes could have been told a bit better in the view of juxta-articular erosions and overhanging edges, sclerotic margins, no periarticular osteopenia, the joint space relatively well maintained as against the severity of the disease process, no other joints being involved. So you would close it as an inflammatory monoarticular arthritis, and then talk about the possible differential, the management, and that's how you close it. So overall, well done. And I hope you do it even better in your examinations.
Thank you so much. Thank you. Yeah.
So I would just recommend all the candidates who are appearing for the Viva, please take the feedback positively. I'm here just to try and help you as much as I can. I may sound harsh, but it's for your own benefit. So
no, not at all. Actually, really, but the thing is that we know the diagnosis, but the description, yes. I mean,
yes, so that's the art that you would need to learn in coming 20-25 days. So once you've known the diagnosis, nail the case and get an 8 on 8, because there would be cases in which you would not be able to score more than 5 or 6 also. So do not lose marks when you already have the hold over the case. So that would be my suggestion to you. And you know your subject, you just need to get it going. That's all.
Thank you.
Best of luck. So the next candidate would be
Dr. Kashfa.
Hi, I'm Dr. Kashfa. How are you, doctor?
I'm good. So hi, I'm Ankit. I'll be just discussing a few cases with you. Take this as a routine day of your practice. And please tell me about what do you think about this case?
So I've been provided a frontal radiograph of the left shoulder joint, in which I can identify multiple fairly well-defined lucent lesions scattered in the scapula, the acromion process, the clavicle, in particular at the medial aspect, and at the image part of the proximal shaft of the left humerus. So these lesions, for example, that at the acromion process, they have a sort of, the cortex is intact. There is no associated periosteal reaction, no soft tissue swelling. Apart from the described osseous lesions, I also see similar lesions in the imaged ribs. Multiple ribs are also showing similar lesions. Apart from the described osseous lesions, I'm just looking at the lung parenchyma to see any incidental masses. So the lung parenchyma appears unremarkable, the soft tissue appears unremarkable. Coming back to the described osseous lesions, the first differential that comes to my mind is multiple myeloma. Another possible differential could be lytic metastasis. So in my normal clinical practice, I would see if there are any prior images available for this patient to see if these findings were seen previously. I would also look at any orthogonal views for this particular presentation to look for any fractures through these lesions which are not visible on this radiograph.
So this was the first presentation of this elderly gentleman, and he had presented with the pain in the left shoulder. So no prior imaging is available. What do you do next?
Actually, further evaluating this provided radiograph, I think that the lateral aspect of the left clavicle, it's not, there may be a fracture there because it's sort of, the orientation is sort of different. So I would want to look at the orthogonal views. So I've been provided with the orthogonal view, and I can see that there is a lytic lesion here in the distal aspect of the left clavicle, and there is cortical expansion, but still I can't see a clear fracture at this point. So in my normal clinical practice, I would want to, I'm suspecting either multiple myeloma or metastasis. So I would discuss the case with the referring physician. I would want to know if there is any patient is known for any primary disease for which these could be metastases. And the patient can be further discussed at the MDT for further management. To look for further lesion, for further workup, depending on the location, for example, in our department, we do MRI to look for further involvement of MRI of the spine, to look for MRI for involvements by the multiple myeloma lesions.
Okay.
Okay, so you
So
want
if you
me
could
to
please request, yeah.
Okay. Yeah, I've requested.
Yeah, here you go.
Okay, so I've been provided with, I'm just going to take a quick look through the images before I start describing. So I've been provided with non-enhanced axial CT of the brain, in which I see a heterogeneous mass in the posterior fossa. Some of the mass is, some regions of the mass are hyperdense, while others are slightly hypodense, and there is surrounding vasogenic edema. The fourth ventricle seems to be displayed slightly laterally, anterolaterally. The most concerning finding in this initial workup is that I see obstructive hydrocephalus. I would pick up the phone and I would inform the neurosurgical team of this because the patient requires urgent VP shunt to relieve this obstructive hydrocephalus. Coming back to the described posterior fossa lesion, as I said, it's mostly centered in the left cerebellum and also then in the cerebellar vermis, causing effacement of the fourth ventricle. In my normal clinical practice, I would want to look at other reformats. Okay, sorry. So there is fullness at the level of the foramen magnum. So there seems to be tonsillar herniation. So this is also another finding that I would convey to the neurosurgical team. In my normal clinical practice, I would want to do, I would look at the other reformats, the coronal and sagittal reformats, and I would also want to do a contrast enhanced study to further evaluate the lesion and to look for any intracerebral further lesions. Okay, so I've been provided with the contrast enhanced, I don't know, it's not moving. Okay, it's moving now. I've been provided with contrast enhanced CT brain of the same patient. I'm just again taking a quick look before I start commenting. So the lesion is seen again at it's demonstrating heterogeneous enhancement. So some parts are enhancing while the other parts, which are possibly necrotic, are not enhancing. So I'm not sure, I haven't been provided with the patient's age, but looking at this, it could possibly an adult patient. So it could be, in posterior fossa tumors, it could be a metastasis, could be an ependymoma. And at this point, I also see another finding in the left globe. There is hyperdense material in the posterior aspect of the left globe, which unfortunately I missed on the non-enhanced images, so I can't comment on the enhancement pattern, but this could be a retinal detachment, which requires further evaluation.
So would you want to review your plain scan images again?
Yes, because I would want to look
do
at the
that.
density. Okay.
So what do you think of it now?
So the finding in the left globe, it's still persistently hyperdense. In my normal clinical practice, I would measure the Hounsfield units to see if it has the
It's
density
coming around
of,
65.
so that's the density of blood. So it's probably related to retinal detachment. This needs to be conveyed to the ophthalmology team for appropriate
what is your
management.
final diagnosis of the case?
Osteofossa mass, I would want to, so this is a posterior mass. It could be metastasis, it could be epenzymoma, or it could even be, considering the heterogeneous enhancement, it could be a GBM as well. So I would want to do an MRI of the whole neural axis to look for further lesions. And also, I think you're showing me another lesion.
No, do you see something in these sections? I'll just bring it back to the point of interest.
Okay.
So do you see something abnormal in these sections?
So there is this sort of dense, curvilinear, serpiginous kind of structure, which seems to be arising from one of the vessels, the posterior communicating vessel. It's
what
seen,
this could be?
It could be a vascular anomaly.
Okay, so what do you do next in this case?
In addition to informing the neurosurgical team, I would do an MRI of the whole neural axis to look for further lesions and to look for drop metastasis.
So what sequences do you want on your MRI to be viewed at the first instance?
I would want to look at the flare.
Here you go.
Is this a spot image or can I scroll?
I think it's a spot image. It's a spot image.
So spot image of the same lesion showing a dense, redemonstrating the lesion in the posterior fossa with high signal intensity, but they're surrounding flow voids. So the flow voids are likely representing vessels. Could be, I'm thinking, although it doesn't show the classical pattern, enhancement pattern of a hemangioblastoma, but I'm thinking along the lines of hemangioblastoma.
So what would you expect if it was to be an hemangioblastoma?
It would be cystic with enhancing a mural nodule.
Okay.
Which it's not. So it's more aggressive looking.
So what would you do next?
I would want to look at the contrast enhanced images.
Yes, I could provide you with one. So it's a static axial section, and if you want, there's a coronal section as well.
So it has a thick, irregular kind of nodular enhancement. And
so the surgeon has already relieved him of the hydrocephalus, and the emergency has been well handled. So what does he do next about it?
So this needs to be discussed at a neurosurgical MDT for further management, and the patient needs a staging CT, chest abdo-pelvis, to look for metastasis. Yeah.
Okay, we'll move on to the next case.
Okay.
Here you go.
I've been provided with the frontal radiograph of the abdomen in a patient in whom I feel that the epiphysis, the head of the femoral epiphysis, haven't fused yet, so it looks like a skeletally immature patient. The vertebral bodies demonstrate a reduced height, sort of like an H-shaped configuration. I'm looking at the bowel pattern. The bowel loops, they show normal gaseous distension. They don't seem to be obstructed. There is a dense oval opacity in the right paravertebral region at the at the level of the upper lumbar vertebrae. And I'm just looking at the other bones. I don't know if the image is pixelated at my end, but the left femoral head also seems to be slightly heterogeneous, sclerotic.
No, I think what you're seeing is right. So
Okay.
it looks a bit heterogeneous to me as well.
Okay, so heterogeneous sclerotic left femoral head with H-shaped vertebra. I'm thinking along the lines of sickle cell anemia. I'm not, but regarding the calcified right paravertebral ovoid lesion, it's too medially located to be a calcified kidney, although that would be entirely possible, because if it was a calcified kidney and the patient had, for example, a transplant and was receiving steroids, he could be having an avascular necrosis of the left femoral head. But it's just too medially located to be the left kidney, the right kidney, yeah.
So do we see calcified kidneys in sickle cell anemia?
No, so it's probably not a calcified kidney.
If I could ask, what investigation is this? Do you have any clues on the?
I initially felt it was a plain radiograph.
Mm-hmm. Okay, so
sure.
what do you do next about this patient?
So in a known, if it's, I would discuss the case with the referring physician. If the patient is a known case of sickle cell anemia, then I would ask the indication for the current radiograph, because all the findings that I see on this are chronic. There's nothing acute that I can see on it. For example, bowel obstruction or pneumoperitoneum. And I would convey the findings of avascular necrosis, possible avascular necrosis of the left femoral head, to the physician and advise an MRI of the hip joints for further evaluation.
Okay, so what do you see in the case of an avascular necrosis? What are the imaging findings that you would expect?
So the femoral head would be, depending on what stage of avascular necrosis the bone is at. For example, if it's a femoral head, it would be slightly deformed, it would be sclerotic, yeah, that would reduced in height.
What do you feel about the contour of the femoral heads in this case?
So the contour is normal, but the overall density, it's like heterogeneously sclerotic.
Okay, great. So
in comparison to the right side.
This is your next case. You could please scroll through the images and let me know what you feel. I'll just remove this ad from below. 1 second. Just give me a second. Yeah, please go ahead.
Okay. So I'm just gonna, the images are still loading. Okay, I'm just gonna take a quick look through the images before I start commencing. So I've been provided with a contrast enhanced CT of the abdomen and pelvis, portal venous phase, in which I can see a loop of small bowel, which is herniating into the inguinal canal and then into the scrotal sac. Moving cranially, I can see there seem to be, there is ascites, and in addition to that, there is a small bowel obstruction, because most of the small bowel loops are dilated with internal air fluid levels, and this is related to the herniated loop of small bowel into the right inguinal canal. Additionally, there are multiple soft tissue masses. The peritoneum anteriorly, there are multiple soft tissue masses within the peritoneum and the omentum. I'm just trying to look for any possible cause for these masses. There is also associated ascites, which seems to be slightly loculated towards the center of the abdomen and also some in the periphery. There is a filling defect in the dependent part of the stomach. The rest of the stomach is filled with oral contrast, but the dependent part...
That was found to be not important. Please ignore that.
Okay. So there is peritoneal nodularity and omental caking, which suggests possibly an underlying neoplastic process. I'm systematically evaluating the imaged viscera to look for any primary lesion, and I haven't been able to see anything in the spleen, liver, pancreas, or kidneys. Just taking a quick look at the adrenals, they seem to be fine. So peritoneal carcinomatosis along with small bowel obstruction related to herniation of a small bowel loop into the inguinal canal. So in my normal clinical practice, I would pick up the phone and inform the surgical team on call regarding the small bowel obstruction. I would also alert the referring physician of the findings of peritoneal carcinomatosis and suggest a CT chest abdomen, a CT chest to look for the primary, because it's not evident in
What are the
this
common sites
scan.
of primary in a case of peritoneal carcinomatosis? I would want you not to scroll any further.
Okay, so it could be peritoneal carcinomatosis could be related to liver lesions. This is a male patient. Otherwise, it would also be ovaries and lung cancers
So
and
in a male
colon
patient,
cancer.
in a male patient, what would be your prime suspicion for
Prostate
peritoneal
gland.
carcinomatosis?
I'd want to look at the prostate gland or the lungs.
Prostate was normal, lungs were normal.
Colon, I would want to take further look at the lungs, the colon
So
in
we'll
detail.
move on to your next case in the interest of time.
Okay, I've been provided with frontal projection of X-ray of the ankle of a skeletally immature patient, of a child. The most obvious finding is that the lateral malleolus seems to be, there seems to be slip of the epiphysis of the growth plates of the distal growth plates of the fibula, and the lateral malleolus seems to be angulated slightly laterally, and there is adjacent soft tissue swelling, and the cortices of the lateral malleolus are slightly irregular along the inferior aspect. This could be related to recent trauma. I'm just taking a quick look at the other bones. The rest of the bones appear unremarkable. So coming back to this finding, there seems to be a slipped epiphysis at the level of the distal fibula. Could be related to trauma. So in my normal clinical practice, I would look at the orthogonal view to look for any further associated injuries. Okay, so there is soft tissue swelling surrounding the ankle joint, which is in keeping with a joint effusion. Just looking at the other bones and joints, I didn't see anything else. So
what do you do next?
I would alert the referring physician of the findings, and I would inform the orthopedic team on call so the patients can be handled appropriately.
Dr. Ankit, just to let you know that the time is up.
Yes, thank you, Dr. Sarda. So this would be your last case. If you could just talk about only the relevant positives, then we would end there.
Okay, I've been provided with frontal radiograph of a baby in which I can see the head of the superior epiphysis of the humerus, so it's not a preterm baby. Just looking at the lungs are slightly hazy, but I don't really see any areas of consolidation. Cardiac size is normal. I don't see any acute, like for example, pneumothorax. The anterior aspect of all the imaged ribs, they appear to be slightly flared. And I think there is some discontinuity along some of the posterior aspect of the left 4th to 7th ribs. So there are fractures of the ribs on the left side. I'm just looking at the other bones to look for any other fractures. I don't see any. I can't see a pneumothorax related to the left-sided rib fractures. So rib fractures in a child are highly suspicious for non-accidental injury. In my normal clinical practice.
Yeah, you could please continue.
Okay. In my normal clinical practice, I would make sure that the child remains in the department while this image is read by a second radiologist. I would make a point to involve social services once the radiograph has been read by a second radiologist. and the patient requires further radiographs of like a skeletal survey to look for any other further injuries.
Okay, so in the interest of time, we would stop here. Well done, Dr. Kashfa. Again, you know the subject, just you need to polish yourself a bit more. You've been verbalizing yourself quite well. It's just that you need to focus on the relevant findings more and talk about the associated findings as less as possible. So in this case, you could have talked about it being a skeletally mature because it is a relevant musculoskeletal radiograph. You rightfully asked for an orthogonal radiograph that I would appreciate. You talked about the MDT referral, but see, you knew the diagnosis. It is one of either multiple myeloma or metastasis. What you could not do further was how to effectively manage this case. Later on, sometime you did say that in your hospital, you do an MRI of spine. The better way to put it would be in my routine daily practice, because you should not show that you are like a overseas candidate. It's better to say that in my routine daily practice. That is taken it as that way better. Second, you could have talked about relevant blood investigations as well, as in you could have done serum and urine electrophoresis as you were highly suspicious of multiple myeloma in the first instance. Second, rightfully you did not ask for a bone scan. Third, you did ask for a staging CECT chest, abdomen, and pelvis. So you should put it, my first suspicion is that of a multiple myeloma. I would start with lab parameters. First is to compare with the records, see if the patient is a known case of either multiple myeloma or any other primary, which could explain the imaging appearances on this radiograph. If not, I would go ahead with the lab parameters like serum and urine electrophoresis. If the patient is found to have multiple myeloma, I would do a skeletal survey. If not, if there's a chances of it being metastasis, I would want to do a staging CECT, chest, abdomen, and pelvis, and would advise an MDT referral. So the earlier you close this case, you get the chance to move on to the next case.
Okay, okay.
Again, in this case, yes, you very rightfully picked up the lesion. I would highly appreciate the way you talked about the obstructive hydrocephalus. You did even realize that there was a tonsillar herniation, which also you alerted. So these were something good that you talked about. But there was a few things which I would recommend you. You talked about vasogenic edema, which I usually never do that in my routine practice, because even on an MRI, what you see as a T2 or a flare hyperintensity, that is not necessarily vasogenic edema always. That could be tumor infiltration, especially in cases of gliomas. So be careful of your words. Second, you talked about the fourth ventricle going anterolaterally. So we have talked about the lesion being in the left cerebellum and the vermis. So it's likely to go anteromedially rather than anterolaterally, right? So
yes, okay.
Again, you could see that there is a ventricle here. So just being more careful of your words, that would be, but it's okay. Such small errors are okay in examination. Second, you told that it is an adult patient, which is okay, appreciable. Next, you talked about staging CT, chest, abdomen, and pelvis, which I would not do in a case of a suspected cerebellar lesion unless it is highly suspicious for a metastasis. So it would not be a staging CT if at all. It would be to look for the primary, and that too only once the index of suspicion for metastasis is high. I showed this case specifically for 2-3 reasons. First is to identify the abnormality on plain scan, which you did. Next, you asked for contrast scan, which was again very good. You identified a second abnormality on the contrast scan, which is again acceptable because you are so engrossed in the main finding in the examination that you tend to overlook the edges. So that would be one take home point. Look at the edges. Second is, see, associations would happen more commonly in examinations. So once you've looked at a finding, in your mind, look at the possible associations that it might have. You even came on to the possibility of an hemangioblastoma, but you could not relate this with this finding. When the examiner gives you an option of going back to the previous images, means that he wants you to look at the previous images again and look for a further finding which you are going on the right track. See, they would not trick you ever in your exams. They are only going to help you out. Okay. So
Okay.
you talked about hyperdensity, and you rightfully said that you would want to look it on the plane scan as to it was hyperdense on the plane scan. So the finding is hyperdense on plane scan, but on the post contrast, there's something enhancing as well. Do you see that?
Yes, now I do.
Now that you've seen this, with this, it makes it a very simple case of an hemangioblastoma with retinoblastoma in a case of a suspected von Hippel-Lindau syndrome.
Yes.
So that's how you get it onto the VHL. Then once you've got onto VHL, you talk about how would you do further in a VHL case. It should be on your tips, because either in your long cases or on your Vivas, all of you are going to get such a syndromic association case. So talk about the genetics, talk about the family screening, talk about the retinal examination, MRI brain, screening spine, ultrasound abdomen, to look for the other associations. Okay.
Okay.
Nothing to feel bad. Even the author who has given this radiopedia case does not feel this is retinoblastoma, but I'm pretty sure these are one, because they're definitely enhancing. So just to keep in mind that once you've got in an abnormality, look for the associations and come to a conclusive diagnosis. Once you've come to a diagnosis, move further, talk about the syndromic association, talk about the genetic screening and the family screening. Next, you could be shown a post-operative scan wherein there could be a craniotomy defect or some focus of enhancement in the cerebellum with a retinal lesion or a retinal hemorrhage. So they may not give you a simple hemangioblastoma. They might trick you in a way that they are giving you a post-operative hemangioblastoma with a retinal lesion. So again, you need to connect the two dots together. Similarly, you could be provided with an abdominal scan wherein you could have renal cyst, renal cell carcinomas, pancreatic cyst, pancreatic adenocarcinomas or serous cystic neoplasms, or else only a renal cell carcinoma with a post-operative spine. So the post-operative spine would be because of a spinal hemangioblastoma that was operated. So keep that thing going on in the examination. This was a difficult case, but such difficult cases do appear in exams also. So first thing is to take up the clue when I told you what investigation is this. You rightfully said that you felt it was a plain radiograph. So if you feel it to be a plain radiograph, you should focus that it is a fluoroscopic image. That means it was some study that was going on and it is a spot image of that, right?
Okay, yes, agreed.
So
I was just focused on the central part of the image and not looking at the periphery.
Correct. So
sorry about
always,
that.
Yeah, so always start looking at the image from the edges. That's how I usually start with the image, so as to first identify that the side markers is right, because they'll give you a cartogenous syndrome and you will talk about everything but cartogenous because you have not identified the site marker. That is number one. Second is identify the study. So once you've identified this is a fluoroscopic study, I would say that I can see some hyperdensity, not only on the right side, but also on the left side. So I'll be concerned whether this is a nephrographic phase or is it a plain scan at the first instance. I would look at the control image. The examiner would say no, this is a plain image. The rest of the study is after this image. So once I've identified this is a plain image, I would say that there are densely calcified kidneys, which are small in size. There is diffuse osteopenia. There are areas of sclerosis, altered contours of the femoral heads, bilateral protrusio acetabuli. Putting everything together in a young individual, these would point towards a primary auxiliosis. So this is definitely a difficult case, but this is an important exam case because of a given reason. First, to identify that this is a plain image, and you would always confirm that it is a plain image. Second, such densely calcified cortical and nephrocalcinosis kidneys in a child are very commonly because of primary auxiliuria. Third, primary auxiliuria presents in a combination of both osteopenia as well as osteosclerosis. So you will see some parts of the bone being penic and some parts being sclerotic. As the bones are weak, they tend to undergo both protrusio as well.
Okay.
Next would be.
Would they be? Is there a chance they'd ask me what next if I'd in the rare instant that I'd actually picked up that this is auxiliosis?
Yes. Yes. So
Is
the
there
next
a
step
chance
would,
they'd ask me for next?
yes, next step would be what would you do next and how would this condition be managed about. So see, once you've identified the diagnosis, I would close the case saying that this looks like to be a primary oxalosis because this is a young child presenting both with penia and sclerosis and densely calcified kidneys. This is likely to be a congenital condition. I would look at the prior records if they're available. If none are available, the child would require workup with lab parameters that would include the evaluation of the liver enzyme, which is responsible for this condition. And once diagnosed, the child would require a simultaneous liver as well as renal transplantation. The renal transplantation would be done because the kidneys are non-functioning. The liver transplantation would be done because the liver enzyme is the deficient factor which has caused this condition. So that's how you close this case.
Okay.
The next was correct. Yeah, you identified the pathology. You went on nicely, talked about, started with the hernia. That's okay. I slightly disagree with the bowel obstruction part of it. Yeah, they are dilated, but not that much. The more important finding would have been the peritoneal carcinomatosis. You rightly identified that the patient was male, which is highly appreciated because you looked at the organs and then you logically thought that there were no ovaries which would have caused this. But then the next step should have been looking at the appendix, because this is not only mucinous, this is not only peritoneal carcinomatosis, this is pseudomyxoma. And you can see that if you see these areas of scalloping of the liver margins. So this is a pseudomyxoma peritonei, and the commonest cause would be an appendiceal mucinous carcinoma, if not ovaries. And then you see this structure. So yeah, such things get difficult in examination. So I always felt that I would be better off if I am provided with CTs and MRs in my examination. But after giving the examination, I felt that it was much better to have radiographs because you don't have to scroll through them. And the technical factors don't play an important role there then. But yes, once you've identified the pathology, you should look at the possible organs and you should come up with the site of the primary lesion as well. Overall, this case was nicely done. And yes, this was perfect. It was a physeal slip. Again, you should close this saying that it is a Salter-Horace type 1 fracture, needs urgent referral to the orthopedic team and informing them over phone. The child would require immobilization. Yes, you did not get much time on this, but yes, this is to show that NAI may come up in the exam. Look at what scan it is. So you started with humeral epiphysis. We tend to keep repeating the stuff which we are trying to look, but no. Non-visualization is important because it's a preterm, and then you should look at the RDS and hyaline membrane disease. Once you've realized that it is a term, you need not say that. Just say that it is an immature skeleton. Then come on to the findings of fracture. Once you've realized that there are fracture, alert. You nicely said that it may be NAI. You would not let the child go out. There is a set answer for that as well. Memorize that. You would involve your you will follow the local protocol to safeguard the child. You will involve the social services. You will do a skeletal survey. There's a good guidelines published by FRCR. Please go through them. It's around 50-60 pages, but it is worth a read. What all skeletal radiographs need to be done. They'll ask you questions as in, if the senior radiologist is not available, what do you do? When do you do a skeletal survey? How many radiographers are required? What training is required on their part? And how many radiologists interpret the scan? When do you do a CT scan? When do you do an MRI scan? How do you interpret them? So such questions are accepted, and they may come up. So the FRCR guidelines mentions all about them. For the interest of time, I'll not be going on to them. Overall, well done. Who's the next candidate, please?
Thank you. Doctor, can you mute me because somehow I can't really,
Yeah, you've been muted by someone. Thank you, whosoever did this.
It's okay. Dr. Nuran, go on.
Yeah, I'm here. Hi, I'm Dr. Nuran. How are you, doctor?
I'm doing good. Hope you're doing well. So this is your first case.
Okay, I've been provided with the MLO and the CC view of the right breast. I can see there is a macrolobulated dense lesion, retroareolar in location in the middle part, causing some retraction in the nipple and some structural deformities around the lesion. Also, I can see there is 3 or 2 lymph nodes, enlarged lymph nodes in the axilla. So all these findings gives the impression of a malignant lesion of this patient. In my routine practice, I would like to look to the other breast also to be sure if there is no any other lesion on the other side, and I will manage. I will refer these findings immediately to the referred clinician to be dealt in the breast MDT or breast center for triple assessment of this patient, radiology, pathology, and clinical picture, because it needs an ultrasound correlation and biopsy sampling. So I will relay all these findings to the referred clinician.
So you said that the lesion was dense. What do you mean by a dense lesion on a mammogram?
Well, it is dense according to the surrounding tissues, because the surrounding tissue looks lipomatous, more fatty, and it looks like dense to me. And macro,
so that means any lesion on a fatty breast would be a dense lesion, right?
Not necessarily. Fatty lesions, no. Sorry for that. But this lesion, it is more dense and it has irregular outline, speculated in outline and causing retraction in the nipple. So all these are malignant criteria for a lesion.
Okay.
Yeah.
So this patient was a 53-year-old female who had come for a screening mammogram. So what do you do next?
Well, I will ask for, I will look to the previous films if possible, because she's coming to the screening exam. So to look to the progression of the lesion.
So are you aware of the NHS breast screening program, doctor?
Yes, yes.
So what age do they start screening the females?
Well, they was actually starting from 50, but now it is taken to the 47 years of age till 73 years. Every 3 years, the scanning will be taken every 3 years in NHS.
Okay, so the previous screening mammogram at the age of 50 was normal. This is the first mammogram which has shown the abnormality. Yeah. So what do you do next?
I will do an ultrasound for this lady, just to be sure of the criteria that I mentioned. And if the lesion is seems taller than wider, and it is hypoechoic and showing an acoustic shadowing in the lesion, so this means that the lesion confirms my suspicions of malignancy. And well, I'm not sure if it is proper to biopsy this patient, then send it to the MDT, or this is that I will ask you about it. I don't know.
It's okay. It's okay. We'll come on to it a bit later. So if you could please tell me your findings on this abdominal CT scan.
So I will ask for a...
Yes, please do so.
Yeah. Okay. So, yeah, I've been, sorry. I've been provided with axial CT in a portovenous phase for an adult patient. I'm just going from up to down. So I've seen there is a scar in the abdomen and I'm going up. Yeah. There is a bowel loop. It is adhered to the anterior abdominal wall with some flecks of calcification. Or, yeah, this is contrast. The liver is not remarkable. The other solid organs, I'm looking to the stomach. Stomach is normal in outline. Maybe here's some thickening in the antrum, but it is,
That was found to be normal. You could please ignore that.
yeah. And the spleen is also normal, no stone in the gallbladder. The pancreas looks normal. So, and the kidneys are unremarkable. But there
So
is,
are you seeing anything remarkable in the scan?
well, the only thing I can see, there is a bowel loop which is dilated here.
Okay.
Yeah, in the lower anterior abdominal wall, which is also adhered to the anterior abdominal wall, and there is a scar in the abdominal wall.
Okay.
So yeah, it could be abdominal wall lesion, or it could be an adhesion there. I'm not sure about the.
So you talked about certain calcifications being present in the lesion, right?
Yeah, but because
So do you expect calcification to come within the lumen of bowel?
well, maybe it is contrast material also, because there is contrast in the other part of the bowel loop.
Okay.
Yeah, so I would like to see in my routine practice the pre-contrast, the plain CT, if possible.
So the plain CT also showed the similar hyperdensity within the so-called bowel loop.
Okay, so that means there is some calcification in the bowel loop.
Mhm.
Yeah, so it could be a carcinogenic material like or it could be the patient may be operated on and has received any radiation. So this could be due to radiation in the bowel wall, the effect of radiation calcification, because I can see there is some linear scar in the abdomen.
Okay. So
Yeah.
the patient underwent hysterectomy for fibroid uterus,
Okay.
and there's no history of radiotherapy.
Yeah, it could be foreign material, or it could be any something swallowed and passed to the bowel wall, or it could be well, there is some flex of hypo-intense lesions. Maybe he swallowed something, or bizarre, or but it is in the lower bowel wall, and or it is calcified.
If I were
Anything.
to think that it is not within the bowel, how would you prove or disprove that fact?
It is not within the bowel. So I will make the patient, move the patient, change the position of the patient, I mean. Then we'll look to it, or we'll ask for ultrasound for this patient. Maybe this is in the abdominal wall. Maybe it is desmoid tumor, and causing some desmoplastic reactions in this lesion. So,
okay, so your final list of differentials, please.
yeah, well, I can see there is a rounded lesion in the anterior, adjacent to the anterior abdominal wall, right parasagittal in location, contains some flecks of calcification, and it could be in the anterior abdominal wall. It could be desmoid tumor, or it could be related to a previous surgery, but however, the patient has no surgery. So I think this is desmoid tumor.
Okay, great. Next, please.
Yeah. So this is frontal X-ray of the knee in an adult patient. I can see there is a pathological fracture through an lytic lesion, which is ill-defined in outline, and it has a wide zone of transition, and there is some permeative lytic lesions also around the main lesion. There is also a flex of or a bony fragment on the adjacent to the distal femur. All this gives the impression of a pathological fracture with a background of malignant lesion, and I will flag this report immediately to the referred clinician to be referred to sarcoma or bone sarcoma center for further discussion and biopsy, and we'll also organize CT chest abdomen for this patient to know for the further of for the aim of staging. And Also, MRI of the knee is possible for the possibility for infiltration. And also, while the patient in the department, I would like to image the whole limb for the possibility of a skip lesion in other parts or metastasis also.
Okay, so what makes you say that it is a malignant process going on?
Well, because the background, the bone in the matrix looks lytic, and some permeative lesions in it, and there is no clear outline, and the wide zone of transition is looks like there is wide zone of transition, and the lesion is metaphyseal, diaphyseal in location and extending somewhat to the epiphysis. All this gives the impression of, yeah. I've been provided with a frontal X-ray of a premature baby. I couldn't see the epiphysis on the top of the humeri, and there is a hazy opacification in both lung fields. I would like also to comment on the tips on the catheters. The endotracheal tube looks well situated. And the nasogastric tube, I can see the distal part of it, but I think it is within the gastric shadow. There is a catheter, which is, I think this is the aortic umbilical catheter. This is below the diaphragm. I think this should be pushed and proceeded a little bit more, because the normal situation is between T10 and T6, and this is below the diaphragm. And the venous catheter also is lower down, and I can see there is a big gas. This is a football sign beneath the diaphragm. This is keeping with the pneumoperitoneum. Also, there is respiratory distress syndrome in this patient because of this hazy opacifications. So this is pneumoperitoneum, and I would like to image the whole abdomen, because in premature baby with pneumoperitoneum, there is possibility of necrotizing enterocolitis, and this is, I will pick up the phone and inform the surgical team on call, because there is pneumoperitoneum and possibility of perforation in this patient. Yes, there is a huge amount of free gas in the abdomen, giving the impression of football sign, with the falciform ligaments also seen, and the catheters are downward, should be should be placed formerly, and this is a, well, I can see the wall of the small bowels, the bowel loops. There is intestinalis, nematose, air in the bowel, nematosis intestinalis in the bowel wall. And because of free bowel, so free air, so this is perforation. And I should, this is emergency. This is emergency case. I can't see anything in the orifices, hernial orifices, and this is very emergent case.
So what do you do next?
I will refer the patient immediately to the surgical team on call, as I mentioned previously, because there is a free air in the bowel and pneumo.
So what do you expect the surgical team to do in such a patient?
They will follow the patient usually, because they follow it. If the patient's situation goes bad, they look to the images 4 to 8 hours, then 8 to 12 hours. If it goes much worse in infant, they will operate it on. But if it gets better, they still follow the patient. Yeah, so this is frontal chest X-ray of an adult patient. I can see an opacification in the right upper lobe or zone of the lung, and the hilum is bulky. The right hilum is bulky, and there is a golden S sign because the fissure is shifted upwards. So all these gives the impression of obstructive lesion causing collapse to the right upper lobe, and in my routine practice, there is possibility of a lung carcinoma. That's why I will flag my report immediately to the referred clinician to be discussed in the chest MDT for the possibility of biopsy, either via bronchoscopy because it is central. And meanwhile, I will book within maximum 2 weeks CT for this patient, CT chest and abdomen for this patient to delineate the underlying condition much better, and also for the aim of the staging of this patient. Because there is possibility of bronchogenic carcinoma. However, there are other possibilities like endotracheal obstruction, like metastasis or inspissated mucus, but the other lung looks clear, so I can't think. I will ask if the patient is asthmatic, but there is no any evidence of cystic fibrosis. So this is much more gives the possibility of neoplastic causes.
So you talked about 14 days. What was that?
No, I mean, I will organize as soon as possible CT for this patient, for CT chest and abdomen, not a long list. Not to put it in the long list, just as soon as possible.
Okay, great. So here's your next patient.
Left kidney abnormal on antenatal ultrasound in 4 months age. Yeah, this is scan, renal scan. Renal scan. I think this is MAC3 renogram. So I'm looking to the excretion of the accumulation first, because this is a functional study. And yeah, I am looking that there is in the series, in the 2 minutes till 1.5 hours, there is accumulation or retention of the radiotracer in the right kidney. And however, in the left kidney, the tracer has vanished and cleared. So this gives the possibility.
Could you please point where the retention is there?
Here.
Okay.
Yeah, here the retention, because I can see it is started from the 2nd minute and extend. The retention is still here, and there is no excretion of the radiotracer. So this gives the possibility of an obstruction in this kidney. The other side looks normal. And I would also, as it is MAC3, so I would like to see also in my routine practice to the scores or graphs of the excretion. However, it is very obvious here there is a retention. Yeah. So in this score, I can see the left kidney. Well, so I retrieve my words. I think the left kidney is the one who's causing retention. I just confused with the sides, and the right kidney is there is also some retention in the right kidney, not a very clear.
So well done, Dr. Nooran. I just give you a feedback. You are able to pick up the findings, you're able to come up to the diagnosis, but you need to work on how you verbalize the cases. In this, you started with right breast mammogram, MLO and CC views. So in the examinations, you shouldn't be talking about the short forms. Always say it's a mediolateral oblique and a craniocaudal view. Okay, so that because there would be certain short forms that you are quite used to, but the UK people are not that used to those short forms. Like, to give you an example, in India, we keep on calling intrahepatic biliary ducts as IHBD.
Yeah, you're right. Yeah.
But in UK, nobody calls them as IHBD. So if I were to say an IHBD dilatation, the examiner would not understand that.
Exactly.
So in examination, always prefer not to say the short forms, number one. Second, you started very well. You described the lesion. You talked it being dense. However, you could not justify what a dense lesion is. When you talk about the density of a lesion on a mammogram, you compare it with the equal density of the normal breast tissue. Okay. So suppose you are seeing this big a lesion, you would compare that with the normal breast tissue for that given volume, and the expected density you would figure out in your mind, and then you would compare whether this lesion is denser than that expected volume or it is lesser than that. Okay. So that's how you come up with the density of a lesion. Third, you did not talk about microcalcifications. Fourth, you did not say that in your routine daily practice, you would use the magnification tools available on your workstation.
Yeah, I forget that. Sorry.
Yes, so you keep forgetting that. It's okay to forget that right now, but do not forget that in the examination, right?
Yeah.
Next.
The thing that I want to ask you, please, I'm just
Yes.
confusing. Do we do the biopsy or send it to the
Yes, I'll come on to that.
Yeah.
So once you've concluded that this looks like a malignant lesion, I don't know what you use at your workplace. In UK, nobody uses BIRADS. They use their own system that is grading the lesions either U1 to U5 on ultrasound, M1 to M5 on mammograms, and MR1 to MR5 on MRs. So you
I
should
forget
say,
to categorize from my excitement. Yeah.
Yes. So you need to control the excitement. You should say that this is an M5 lesion.
Yes.
High chances of it being a neoplastic process, a malignant neoplastic process. The next step that you would do in such a case would be to take a lateral and a compressed radiograph. So as to yes, whenever you found out a lesion on a mammogram, the next step would be to do a lateral and a compressed radiograph. Mammogram, sorry, that would confirm the presence of a lesion. Once that is done and properly characterized, the next step would be to do an ultrasound breast. Ultrasound breast would further characterize the lesion, confirm your findings. Once you've done that, you would say that you would put the patient onto the upcoming breast MDT. Next, you would yourself do the biopsy using a 14 gauge automated breast biopsy needle. This is when you are confident enough and you have done the Viva very nicely. If you still feel that you are not that confident and you would not do that, you could very well say that you would refer the patient to a breast clinic for a triple assessment, which would include radiology, pathology, and the clinical examination.
Okay, so but we can do our,
Yes. If you can take the case in a single breath, I would do that. I would describe the lesion. I would talk about the relevant positives. The positives would include nipple retraction, skin retraction, no skin thickening, presence of lymph nodes. So this is an M5 lesion with possible malignant neoplastic process and a possible metastatic lymphadenopathy. This would need further characterization with a compressed and a lateral mammogram. This would need further ultrasound for characterization. And I would also do a breast biopsy using a 14 gauge automated breast biopsy gun. Once I've done that, by the time the patient awaits the report, I would also post the patient in the upcoming breast MDT. Because see, this patient has come on a screening mammogram. There's no point wasting the time and sending them back home and then calling them later. So once the patient is with you, do all that is needed. At the same time, you would write a referral letter to the GP, informing him about the findings that you have picked up on the screening mammogram. Also, you would write a letter to the surgeon on call, to which this patient would be now referred to in view of this concerning finding. Okay.
Thank you. Yes.
The next would be this case. Yes, you kind of lost the track. You could identify the finding and then you started saying that the livers are normal. There's nothing remarkable in the liver. See, such words don't look good in the examination, right? There's nothing remarkable means the liver is not there. It's there, right? It's normal. So not remarkable is not a good word to be said in examination. Say that confidently that the liver is normal if you feel that it is normal. Okay. Again, you spotted the abnormality in the first scroll. You talked about it for a sentence and then probably you were not that confident. So you moved on to other ancillary things, which you should not do, because see, you're just wasting your own time. So you know that the liver is normal. You know that the gallbladders are normal. The kidneys are normal. So don't waste time on that. Come on to the abnormality. Talk about the logical differentiation. differentials. So I'm absolutely okay with you not getting the diagnosis, but please don't waste your time on the ancillary findings or the ancillary things which will not add up to your score, because you're not saying anything positive there, right?
Okay.
So it's just waste your time. So in this case, yes, you talked about a lesion, you talked about the hyperdensity, you talked about comparing it to the plane scan. And when the plane scan has shown that it is same on the plane scan as well, with the mortal lucencies within, the first thing that should come to your mind should be a gossipy bioma. That's a retained swab kept within the abdomen from a previous surgery. You get the clues from the scan itself that there was a recent surgery done. You asked me as well, I told that there was a hysterectomy done. So that should alert you that there is a recent post-surgical patient. So in such a scenario, you could say that
Yeah.
if the patient has recently underwent a surgery, I would be concerned about a retained foreign body that is a gossipy bioma. And I would look at the records, and this needs to be urgently highlighted to the surgeon,
Yeah. Yeah.
because this needs to come out, because if it gets infected, this would be the source of infection to the patient and cause the problems further.
Yeah. 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 Right.
Next, you talked about this case. Nice thing was one thing that you did not do was ask for an orthogonal radiograph. We keep forgetting that. Do not forget that in the exam. Any MSK radiograph, you need to have an orthogonal radiograph to confirm.
Right.
Next, you talked it being a malignant process. I questioned you also. See, whenever the examiner is either interrupting you in between, either he's trying to check your confidence, which will be only in a few cases, or else he would be wanting you to give certain hints. So when I've talked to you that is it a malignant process, what helps you say that it is a malignant process? So that should alert you that the word malignant may not be the right word. So it's an aggressive lesion. You do not know that it's a malignant process, right? Even a very bad osteomyelitis on a rare instance might look like this. Even an eosinophilic granuloma might look like this. So it's an aggressive bony lesion, not a malignant lesion. Both of them are different. So be very careful with the words that we use.
Right.
Similarly, when you said that it was a bowel lesion, I kept on saying apparently bowel lesion. So that should alert you that it's not, it may not be a bowel lesion. That's why the examiner is saying apparently bowel.
Yeah.
Otherwise, I would have also agreed that it is a bowel lesion. Second, again, I gave you a hint. What if it was not a bowel lesion? So you should say that I would try and see the continuity with the bowel above and below. So if it's a bowel lesion, it should continue with the bowel on both the sides. If it is not, it's an extra luminal pathology that's going on. So otherwise, yes, everything correct. You identified the pathological fracture, you identified the aggressive lesion, you referred to the bone tumor unit. You do not do the biopsies on your own. You just refer it to the bone tumor unit for biopsy and MDT consultation.
Yeah.
Yes, in this case, you were spot on. You identified the premature infant. You talked about the hazy lungs. But see, again, once you've identified that there is a sinister pathology going on, talk about it first.
Okay.
Do not waste your time on certain things which are not that important than the main pathologies. So talk about the pneumoperitoneum first, move on to the other findings. When you're describing respiratory distress syndrome, you need to talk about the retained lung volumes or small lung volumes, because RDS will usually present with small lung volumes. So as I told you in the long case in my presentation, any lung pathology with interstitial changes, you need to talk, the next thing is retained lung volumes, normal lung volumes, or increased lung volumes. So do not miss those important things.
Okay.
So these are small things which will make you stand out from the other candidates, because everybody is going to identify this is a respiratory distress syndrome. What you could add is what is more important. You should talk about presence of pulmonary interstitial emphysema, talk about the pneumothorax, talk about the reduced lung volumes, and most importantly, talk about the pneumoperitoneum. Next, I think that the catheters are quite okay, T6 to T10. So this would be somewhere around T9, T10 only. So this is okay. And this is also not going into the porta or the portal vein. Again, I feel this is to be okay, but yes, just to go through the normal positions of these radiographs again. Next, one such case is going to come. Like I said, for one syndromic association, one of the lobar collapse will come to either of you in either long cases or the vivas. It is the bread and butter, and you cannot falter on that. So what you said was, you talked about the sign, like in football sign also, you talked it is a football sign. I don't know what the football sign is, right? So you should explain it to me that you're seeing the air and you're seeing that everything is pushed towards the center, giving the impression of a football sign. Similarly, you talked that there's a golden S sign. I may not know what a golden S is. Even if I know, I would want you to verbalize first what a golden S is, and then comment that it is a golden S. Okay.
Okay.
So yes, you rightly identified there's a right upper lobe collapse, there's a malignant process going on. You put him on a 14-day wait period. That was also perfect. I just wanted to know that what you're saying is by the knowledge of knowing it. That's
Yeah,
why
I heard it
questioned you.
somewhere.
Yes, yes, you heard it quite right.
Yeah.
So what happens usually is, see, these referrals are coming from GP. So if I just issue this report to the patient, the GP would see this report after a week. The patient would come to him after a month or 2 months or whatever, and then they realize that there's a neoplastic process going on. So that is not justifiable, right? So what you do in such a scenario is you flag the case. So this is a case wherein you need to use the flag option.
Yeah.
So you flag the case, you let the GP know that there's a neoplastic process going on. You put the patient on a process in which the patient would meet the appropriate physician in no more than 14 days with all the appropriate investigations already done. So that's what the 14-day period is. So once you have identified there's a possible bronchogenic carcinoma, you put the patient on this cycle so that the patient gets to visit the physician in no more than 14 days.
Okay.
Next, you tend to get excited after seeing such easy cases. So you never talked about the rest of the lung. You did not talk about if there are any other metastases on the contralateral or the ipsilateral lung. You did not talk about the osseous metastasis. What I was expecting from you would be, you would just say that both lungs are normal, the bones are normal, this is normal, this is normal. So in that, what happens is you fail to realize that there are 24 ribs, like 12 on each side, 12 dorsal, 2-3 cervical lumbar, 2 scapulae, and 2 clavicles. So you cannot look at them in just a second. So take a pause at that. I'm carefully looking at the visualized bony skeletal, so that the examiner knows that you are actually trying to look. Otherwise, what happens is you just say it for the sake of saying, and you never look at it. If you would have looked at it, you would have realized that there is a lesion in the right clavicle, there's a lesion in the rib as well. So it is okay to take more minutes on this scan because this is a 8 on 8 for you, right?
Okay.
So take more minutes, try and stage it on the radiograph itself. So if you have seen, for example, a big lesion here, and there's a nodule here, and there is a lesion here. So you can say on radiograph, the lesion looks around 5 centimeters. So that would make it a T2. And I'm seeing a lesion in the contralateral lung. So that will make it an M1. And there is a metastasis as well. So the lesion is at least a T2 M1, and this would need further workup with a contrast enhanced CT chest and upper abdomen. Or else, if you have already found out metastasis, then whole abdomen as well.
Okay.
Okay. So this was your next. Again, see, I did not provide you history in most of the cases, right?
Yeah.
But there was a history provided here. That was because, so as to give you the clue that it was a left kidney. Again, when I asked you, could you please show me? So see, the examiner is not interrupting you again and again. So when he interrupts you, try to find out why he would have interrupted you.
You're right.
So you very rightly identified that this is a dynamic nuclear study. Do not go on to the specifics of the tracer. You might not be able to see that on the images provided. They may or may not show that. If they've shown that, say it confidently that it is a dynamic MAC3 scan. If not, just say that it is a dynamic renogram. That's okay to say. It's a nuclear study, a dynamic renogram. What happens in a renogram is you acquire posterior images. So the sides gets flipped. So you see the left towards the radiological right, and the right vice versa. Okay.
Good.
So otherwise, it was perfect. You said that it is taking up the contrast and it is not excreting, suggesting that there is a PUJ obstruction going on. You would next again correlate with the routine radiological study, which in this case would be an ultrasound,
Yes, yes, yeah.
which the history already said that there was an abnormal kidney. So you would say that I would correlate with the ultrasound findings and see if there was a dilatation of the pelvic lysis system, which
Right.
would confirm the findings of a PUJ obstruction. I would look at the curves, which you rightly did. And before moving on to the function, the first step is to identify the kidneys, whether they are present, number one. Number two, if they're in their normal location. Three, if they have their normal shape.
Yeah.
Fourth, talk about the functions. So talk about the anatomy first, the other relevant findings, and then move on to the function. So take your time, enjoy the case that you've been provided, and then come on to a diagnosis and then move further, okay? Because if you rush through, you're losing a few points in the process. So don't let that happen, especially in cases when you know the diagnosis. So take your time.
Yeah.
It's okay not to see 10, 15 cases. It's okay to see 4, 5 cases, but come to a logical diagnosis and ace
Right.
the case,
Right.
okay?
Thank you. Thank
So
you.
Dr. Sabat, do we have the time for the fourth candidate or we stop here?
And if you are willing to take the fourth candidate, yes, we can proceed.
I'm okay if the people are okay to attend it
Yes,
further.
sure,
Okay.
why not? Dr. Waleed, go ahead.
Hi, Dr. Ankit.
Hi,
How are you?
I'm doing good. So same as others, I'll be just discussing a few cases with you. Treat me as your colleague and please tell me what you think of this case.
Okay. This is a frontal chest. This is a frontal abdominal radiograph of adult patient refilled. There are multiple linear sheets of calcifications noted within the abdominal cavity. There are multiple surgical clips noted within the left hemipelvis. The examined skeleton appear unremarkable. There is also, I think, foot thumb printing noted within the ascending colon.
So that was found to be not significant. You could please ignore that.
Okay, so to summarize my finding, I am suggestive of diffuse peritoneal calcific foci, which may suggest a malignant process within the peritoneum. However, I couldn't see any soft tissue masses. No evidence of bone metastasis could be detected. I would alert the referring physician about that and recommend for CT, enhanced CT abdomen for further characterization of these calcifications.
Okay. So in addition to malignant process, are you concerned about any other differentials?
It could be related to previous peritonitis. So I would like to correlate with previous studies if available, and correlate with patient clinical and past history.
Okay, so you talked about certain surgical clips in the left iliac fossa. What do you think they could be?
It could be related to previous hemicolectomy or something like that, because it is extending into the left iliac fossa down to the pelvis.
Okay.
So it is going with metastatic, maybe diffuse peritoneal metastasis from previous malignancy if the patient is known to have colonic cancer.
Okay, great. So this is your next case. What do you think about it?
This is a frontal chest radiograph of adult patient. Refilled. The main abnormality I could detect here is the left supraclavicular soft tissue lesion noted. However, there is no evidence of tracheal shift to the other side. When I take this case systematically, there are sternotomy sutures noted. There is changes related to cardiomegaly. There are multiple surgical clips also noted within the left hilum. the lung parenchyma bilaterally appear unremarkable. When review with chest skeleton on the right side appear unremarkable, on the left side also appear intact, no evidence of lytic or sclerotic lesions. So to summarize my findings, this patient is complaining of cardiomegaly with evidence of previous surgical open heart surgery, and there is evidence of right central venous line which appear in appropriate position. There is left supraclavicular soft tissue lesion which could be related to thyroid enlargement, which is less likely due to no deviation of the trachea. It may be also related to enlarged lymph node. I would convey my findings to the referring physician and would suggest for ultrasound examination of the neck.
So what are you worried about, the left supraclavicular thing or the cardiomediastinal region?
I think the cardiomediastinal region is a chronic thing. Patient maybe have open heart surgery before, and this clips related to the previous surgery.
So
but I am
the patient has presented with recent onset worsening, and he had an CABG done 3 days back.
In this situation, I would suspect the complication of the previous operation. So I suggest referral to call the cardiologist and discuss the case with him for and arrangement for echocardiogram and chest enhanced CT chest to exclude any possible post-operative complication.
So before doing a 2D echo or CECT chest, could you do something else before that?
I could relate with the previous X-ray.
So here you go.
This is before I was provided with previous X-ray image of the same patient before the operation. The heart appear of average size with no evidence of cardiomegaly. So I am suspecting the picture which is seen in the previous film to be post-operative complication, could be related to mediastinal hematoma or pericardial effusion or something like that.
So it's a static image of a contrast enhanced CT of the same patient.
This static image revealed there is a mottled appearance noted within the anterior mediastinum anterior to the aortic arch with hyperdense foci, which could be related to surgical clips or other possibility of retained towel, surgical towel in this region. Other possibility of complicated post-operative collection. I would like to review the whole study to exclude the possibility of enhancing outline, which going more with post-operative abscess collection.
So this is your next case. If you could ask for remote control, I will give it to you.
Just a minute. I asked it for it. Okay. I will take a view on the whole study and after that comment on it. This is axial CT chest of adult patient with within lung window refilled. There are multiple irregular shape cystic areas noted, mainly involving the upper lung bilaterally. There is no obvious nodulation could be detected. Unfortunately, the study is not covering the lower chest to exclude the possibility of involving of the lower costophrenic angles. The visualized cysts appear of variable bizarre shape size. So if the patient of non-smoker patient, I would suggest the possibility of Langerhans histiocytosis. Other less likely possibility of cystic lung disease as lymphangioliomyomatosis would be considered less likely. This is a CT, axial CT brain of the same patient. There is evidence of high skull vault bony erosion noted. I would like to view the bone window. It is not working. Yeah. In bone window, this confirm my findings of lytic lesions noted within the high vault of the skull, which is going with Langerhans cell histiocytosis. The remainder of the examined bone within appear unremarkable. I would convey my findings to the referring physician and refer the patient for immunology clinic for MDT discussion. This is frontal abdominal X-ray, which revealed there is evidence of central bowel dilatation noted, likely small bowel dilatation, with calcific focus noted within the mid pelvis, which raise the possibility of gallstone ileus. I would find here there is a bile noted within the common bile duct, which is going with that regular triad of aerobilia and bowel obstruction and ectopic gallstones. These findings are consistent with gallstone ileus. I would convey my findings to the referring physician and arrange for urgently call the surgical team to take action in this process, because it may need urgent laparotomy, and if the patient is stable, and they may ask for CT, enhanced CT abdomen for confirmation.
So you said that this was a small bowel which loops which are dilated. How do you say that?
Because vulvular convenance, I see vulvular convenance appear in this central position, vulvular convenance, no evidence of colonic dilatation.
Okay, and are all the three elements of Wriggler's triad present in this case, or there are some and there are certain missing?
I think the 3 points here, aerobilia, which is confident here in the common bile duct, small bowel obstruction, ectopic gallstone ileus.
Okay, so this is the CT of the same patient. You could scroll through the images and tell me.
Yeah. I will take a look. This is axial CT scan of abdomen. Which confirm my finding of ectopic gallstone noted within the distal ileum with associated mild dilatation of small bowel within central abdomen and associated air noted within the biliary tract. I would
Yes, you please continue. You would?
I would keratinize the area of gallbladder and the duodenum to exclude the possibility of the high possibility of cholecystoduodenal fistula.
Okay, great.
This is frontal chest radiograph of skeletally mature patient, erect position, revealed. There is no striking abnormality I could detect in the first look. However, I will take this film systematically. The apex appear normal. The retrocardiac, there is no evidence of retrocardiac shadows. Subdiaphragmatic area, no evidence of pneumoperitoneum or calcifications. Chest skeleton on the right side appear 2, 3, 4, 5. Appear normal on the right side. On the left side, also appear unremarkable. Vertebrae appear intact with no evidence of lytic lesion or depression of the end plates. Mediastinal contour. I'm not appreciating the.
So could you review your review areas again?
Apex appear intact. No, if sorry. The main abnormality here is noted within the left shoulder, whereas there is supraclavicular, and even the scapula appear distracted here with soft tissue calcification. I couldn't see in this film the humeral head. So I am suspecting some mass around the left scapula. I think with soft tissue component and the calcification. So I'm suggesting aggressive mass. I would go for this for further characterization of this lesion with enhanced CT or enhanced MRI.
So what would you prefer, a contrast enhanced CT or an MRI?
A CT will delineate the skeleton more properly, and the MRI will delineate the soft tissue component more accurately. So
So the surgeon comes to your room and says, "Hey doc, what do you want me to do next?"
I would like to start with CT.
Okay, so the radiologist on call instead asked for an MRI, and these are the MRI images. If you could go through them and let me know of your diagnosis.
Okay. This is a fluid sensitive sequence with fat saturation revealed. There is evidence of high intensity soft tissue component noted around the left scapula, which is confirm my findings on chest X-ray. I would like to see T1 and T1 with contrast for proper characterization of this lesion.
So the contrast was not done, and you have the option to see the sagittal T1s.
Yeah. This is sagittal T1 of the left shoulder revealed. There is evidence of scapular destruction here, with surrounding mainly soft tissue component within the supraspinatus region, with combining these findings with the findings in X-ray of presence of calcification, I think possibility of Ewing sarcoma versus osteosarcoma is in the top of the differential. Other possibility of chondrosarcoma is less likely due to the age of the patient, because the patient here is skeletally immature.
So what do you do next?
I will alert the referring physician about that and referral the patient for sarcomatous higher center to arrange for biopsy there, and arrange for staging CT, chest, abdomen, and pelvis.
Okay.
This is a frontal radiograph of fluoroscopy study scout film of a neonate revealed there is evidence of significant dilatation of the upper bowel. This extension is noted extending down to the right iliac fossa. No evidence of air could be detected within the rectum. This possibility is suggesting bowel obstruction, mid-gut bowel obstruction. No evidence of pneumobilia or pneumoperitoneum, air within portal vein or pneumoperitoneum could be detected. No evidence of pneumatosis intestinal could be detected. So I will confirm the referring physician about that, and I would recommend for enema study, enema contrast study, to exclude the possibility of in this patient like meconium ileus or Hirschsprung disease or meconium plaque syndrome.
Okay, so you said that there is no pneumoperitoneum. The surgeon on call is highly worried about the possibility of a pneumoperitoneum. What could you offer him next?
In this case, I would recommend for lateral decubitus for this patient with the right side up to see if there is free air will be collected on the surface of the liver.
Okay, and you talked about the differentials of meconium ileus, meconium plug, and Hirschsprung. And you said that there was no rectal gas shadow, right?
Right, so Hirschsprung will be very less likely in this case because the colon is not dilated.
Okay, so your prime differentials are of?
Meconium ileus and the meconium plug.
Okay, so what do you do next?
Contrast enema.
These are the contrast enema images. I'll scroll for you.
Okay. Here the contrast is entering the rectum with diameter is more than the sigmoid. The smaller caliber of the sigmoid and descending colon is noted. It is in confirming that there are multiple filling defect with a small diameter of the caliber of the colon extending down to the also involving the transfers and reaching to the terminal ileum with multiple filling defects. So it is going with meconium ileus. I will convey these findings to the referring physician, and I think this is considered to be a therapeutic for the patient.
Okay, so well done, Dr. Walid. How do you think you did it?
I don't know. You tell me. This is very nice case, but the first one I get lost within this case.
Okay, so you did well. So as like see, all four of you wonderful as regards to radiology and knowledge is concerned. But when it comes to presenting, I think you need to polish yourself more. More so the reason why, because you know this content very nicely, right? So when you know the content, when you know the subject, you should not fail. That's what I would want from you people. So suppose somebody is lacking in the content, then he cannot do much about it. But somebody who knows the subject, who knows the content, you need to work on your skills to present, and you need to get out of it. You should not have any fear of the vivas, because what you're doing is very nice. It's just that keep practicing, keep polishing your own skills, how to present. And if you
Yeah,
would have realized attending these sessions, see, there are a few cases which keep on coming here and there, right?
yeah, yeah, you are right.
So at least for those cases, you cannot falter. Something which is like a primary auxiliuria or something like that, it's acceptable if you do not come to a diagnosis or you struggle with the case. But something like a right upper lobe collapse, you cannot falter. Something like meconium ileus, you cannot falter. Okay.
Right.
So keep practicing those cases again and again. Coming to the feedback, see, you spot on picked up that there were sheets of calcification. That's a very good way of describing them. You picked up the surgical clips in the left iliac fossa. So I thought in initial 10 seconds that you are going to get 8 on 8 on this exam, this case. But then you kept on losing the track, and you kind of let go of
Yeah,
what you
right,
had
right.
earned.
I couldn't contact these two things with each other.
Correct, correct. So
Yeah.
in such a scenario, buy yourself some time. Look at the relevant positives. You very well said that there is no obvious soft tissue mass. You said that your first differential would be of a metastatic peritoneal carcinoma. You thought about some surgical clips. The examiner then asks you, is there any other second differential? So that again should alert you. Yes, you are probably on the right track, but he wants to have some other differential from you. And then you should come to a diagnosis. See, this is a case of an encapsulating sclerosing peritonitis. Okay, so that has calcified. So the most common differential for that would be in a UK setup would be of that of a chronic peritoneal dialysis catheter.
Oh, right, right.
So you saw the surgical clips in left iliac fossa. So that is undisclosed renal transplant that the patient had underwent. You can see a large number of vascular calcification that shows that the patient must be diabetic. So that is the reason why his kidneys failed. He was under peritoneal dialysis that caused his encapsulating peritonitis. And for that, he has underwent a renal transplant. So it's absolutely okay to give the differential of metastasis first. Talk about the left hemicolectomy. That also is acceptable. Exactly same imaging features could have come with that. But when asked for a differential, you should come up with the second differential. There are multiple other ways in this. The similar radiograph could come to you. The examiner may show the rugger jersey spine. Same radiograph with rugger jersey spine. Same radiograph with chondrocalcinosis. Same radiograph with cortical nephrocalcinosis or medullary nephrocalcinosis. Same radiograph with a Brown's tumor. So keep your mind open. Once you've come with a diagnosis, look at the possible differentials, look for the possible imaging features of those differentials.
Right.
Okay.
You are right.
So you would have definitely scored a 7 on this, but the way you started, you should have gone for an 8. Okay.
Right, right.
Next, again, see, you made up your mind that this was a chronic condition, which is not right. You identified all the possible findings that could have occurred on this radiograph, but then you said that there's nothing significant and you would be wanting to do an ultrasound. I willfully kept silent, though the examiner in real life would have told you that this is non-significant, ignore this. But I twisted my question in a way that would you be worried about this or the cardiomediastinal? So you should have told that no, I will be worried about both of them, because you should not let the patient go with something significant. So you would see why the patient has presented, and the examiner then says you that, yeah, he had an CVG done 3 days back. So a recent surgery means he would have underwent a radiograph before that. So you would see a pre-op radiograph. Seeing the pre-op radiograph, you would realize that no, this is dilated. That means there's something sinister going on. Next would be, you said that you would go for a CECT or a 2D echo. 2D echo, totally acceptable. better would be to do a contrast enhanced angiogram study of the chest, because you're suspecting a mediastinal hematoma. That's what you said on a plain radiograph, right?
Right.
So once you have identified the pathology, ask for the relevant investigation, because the CECT, they might just do it on a venous phase, and they do not, they might not take the arterial phase. So go for an angiogram study, and then you would be provided with an angiogram which would either show a leaking vessel or just a
Right.
hematoma with post-surgical changes. Next thing that you are likely to have in your exams as well is the bias. Like I just showed you a gossipy bioma. So you're likely to think on those lines. So treat every case as a new case. So
Right.
you saying gossipy bioma in this case is not wrong. It might very well be, because it's just a static image. But we'll just use this as an opportunity to tell you that such a bias is likely to happen in the examinations as well. So like some of you colleagues might have told you that I saw such a case, or else you must have seen a case just 2 days back in a Viva mock exam. So do not link the two different cases to be one, but yes, keep your mind open. And yes, you came to the diagnosis, but I would have preferred if you would have been more confident on that. Next is, yes, absolutely spot on. This is an LCH. You told that the entire lung is not covered. You talked about the relevant positives, the buzzwords of bizarre shaped. You told that there are no cavitating nodules, but then the examiner might show you that there are a few with the cavitation. So when you know that there could be cavitating nodules, you say that I'm looking out for cavitating nodules, which I'm not able to appreciate right now.
Right.
Rather than confidently saying that there are none, because you know the diagnosis is LCH, right? So
Right.
once you know that it is pulmonary Langerhans, look for the features. So say that I'm looking for this, I'm looking for pneumothorax, which is not there.
You
And
are
then again, you did not talk about the maintained lung volumes. So see, you would be penalized for such things. So in spite that you've come with a diagnosis, you did not talk about the maintained lung volumes, you will lose 1 mark on that.
Okay.
Next is perfect. You talked about the lesions here in the skull. If you see that there are further as well, so it's okay. In exam, if you miss 1 or 2, it does not make much difference. But yes, the diagnosis was correct. The management was correct. Next is this. Yes, this was absolutely spot on. Okay. So yes, all the 3 things. Again, I would recommend talk about the finding and then talk that this is so and so sign.
Yeah, you are right. You are right.
Right?
I must describe first, and after that, it is consistent
Yes,
with.
yes, because see, you know it. So why not take the advantage and get 1 extra point out of it?
Right, you are right.
That will help you if you falter in some other case. So go slow on such cases. The moment you saw the radiograph, you were absolutely spot on. When I saw in my preparation the first gallstone ileus, I could not crack it. Okay. So I was
Right.
struggling with it. So you're much better than that. You have already spotted the abnormality. So take the advantage and then move on to the case. So perfect. This was small bowel, gallstone, pneumobilia, showing the CT just for the sake of completion. But in examination, you would not be shown because you've already done everything that you could on the radiograph itself. So very good on that.
Thank you.
And yes, this again, nicely done. It's okay to say that you're not seeing anything. It's okay to say that you're looking at the review areas. When you've said that the right is normal, left is normal, see, you've gone very systematically, but then if you're saying so systematically, we would expect you to be looking at the abnormal, like the findings also.
Yeah,
so when
yeah.
you say that there's nothing on the left,
Yeah.
there should be actually nothing on the left then.
Yeah,
Because
it makes the examiner get worry about you because you
yes,
didn't examine
correct.
critically. Right.
Yes,
Right.
yes. So you would have definitely scored a mark because the way you went on to it, you did not just say that the bone window is normal. You spent your time, you said the ribs okay, the right side is okay, the left side is okay. But then you just kind of got a half mark deducted because the left side showed abnormality. But
Right.
it's okay in the exam stress that such a thing happens, and especially for these areas. So look at the lateral end of the clavicles, look at the scapula. There might be a Ewing sarcoma in the
It is
clavicle. There
very,
might be
very
a,
subtle, very subtle
yes,
scapular
yes,
erosion.
yes. So subtle humeral head lesions. So they're likely to happen. So look at the edges always.
Right. You are
Next,
right.
next you said that once you've identified, you characterized it also perfect. You gave the valid differentials also, but then you asked for a CCT. You have already noted that this is a child. So why radiate the child? Should go for MRI first.
Right.
Once you're on MRI, again, you perfectly told about the possible Ewings and osteosarcoma slightly less likely and chondro unlikely. So acceptable. Next, referral directly to the bone tumor unit. Let them do the biopsy. Let them do the MDT discussion. Let them stage the disease. Okay. So
Right.
rest everything perfect. This was a post operative scan in which the scapula was removed
Hmm.
and the patient's undergoing chemotherapy. This was a case in which I would have expected better from you, because this is a routine expected case, would come somewhere or the other. So you've talked about the bowel dilatation. You've rightly told about pneumoporta, pneumoperitoneum. Next thing you talked about was the rectal gas shadow. Perfect till now. Then you lost the tract. Then you did not say about the calcifications, the mesenteric or the
I couldn't
scrotal
appreciate here.
calcification. So you say that you're not seeing it,
Right.
right?
You are
Because
right.
because you know it is either of the 2 or 3 possible differentials. So come step by step onto one of the likely diagnosis. So next you talked about that there is no rectal, but you gave the differential of Hirschsprung. So
Right.
that means the examiner is worried whether you know it or you don't know it, because the way you were talking, I thought you know everything. But then giving the differential of Hirschsprung again deducts a half mark from it. So don't do such conflicting things.
Right. You are right.
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 Next, you gave the 2 differentials of meconium plug and ileus. There could be a third possibility also of an ileal atresia.
Right. You are right.
So
Ileal
ileal atresia is also a valid differential on the radiograph. And to rule out either of these 3, you would do the enema. Enema, again, you said that the rectum is dilated and sigmoid is normal. So which again conflicts your thing. You said that it is not Hirschsprung, and the rectum is ideally not dilated and the sigmoid is more. So the recto-sigmoid ratio is normal in this case, right?
Right.
So start with that. The recto-sigmoid ratio is normal. Next, you rightly told about the filling defects, microcolon, the reflux of contrast into the ileal loops, and the diagnosis of meconium ileus. So in this case, you would say that the contrast is now refluxing back into the ileal loop, ruling out ileal atresia. So initially you should have mentioned ileal atresia as a differential, and then on this you should have ruled that out and said that now I'm confident that this is meconium ileus. Meconium ileus enema could be therapeutic as well. So we would follow up the patient. If he's relieved of his symptoms, this would be therapeutic. If not, enema could be repeated as well. Next, you should take it further that this is known to be associated with cystic fibrosis. You would do the genetic workup, you would do the family screening, you would look for the other associations.
Right, you are right.
Right? Because see, you've come to the almost end. Why not take the extra inch and get the 8 out of it?
Right.
So with that, best of luck to everyone.
Thank you. Very, very thank you. Thank you, Dr. Ankit.
And there are a few questions which I would just take in a minute. Which course you prefer? See, anything which gives you the feel of the exam is okay. Take a course which is within the budget, because there are not many courses. They're all expensive. I'm not a big fan of the expensive ones. I took a on-site course here in India, which gave the feel of the actual practice software. So if you